Hospital CEO, and we're also welcoming Joe Fawkes, who I can see as the Interim Hospital Chief Operating Officer. Have we got any? You're both very welcome. Have we got any other apologies? Claire? No? No. No other apologies. Any declarations of interest? No. Can you take the minutes of the public meeting held on 28th of January? Are you happy to refer record? Silence will do as assent. A few nods would help. Good. Thank you very much. And you have matters arising. 1 to 4 is actually on the agenda on the BAME staff support on EDI, equality, diversity and inclusion, and the emergency preparedness annual report. We've got a date to be confirmed, which no doubt will happen at some point. Okay. Staff story. Medical Director, Metcalf.
Yes, Chair, with sincere apologies to the board. I have to say, to announce that at short notice, the member of staff concerned is unable to be with us today. I know that if he were here, having spent some time with him, he would illuminate for us the experience of a clinician involved in an EVER event. I met with the teams involved in the events last autumn, and so know for certain the commitment of our teams to delivering safe and high quality care, and the impact upon them directly, personally, when things go wrong. I'd like to assure the board that the approach that we have taken in response to said incidents has been entirely supportive and orientated around learning and improvement, with avoiding any elements of personal blame for the teams who have been involved. As some will know, we undertook a thematic review to pull out the drivers behind the events in question, and what came through quite powerfully was the context of staff with a degree of trauma from the first wave of COVID, sort of affecting their performance and functioning to an extent. A real sense of pressure out of professional commitment to patients who they knew had been waiting for a long time during COVID, and a desire to attend to those. And then some real themes emerging from, out of necessity, creating COVID safe pathways rather than traditional speciality specific pathways, with the inevitable disruption to normal teams, to normal environments of working, and a degree of dilution of specialist expertise. And we've taken all those factors into account as we are planning our restoration of non-COVID activity as we come out of the current wave, and the programmes of induction for staff back into non-COVID clinical activity. We very explicitly include sessions on team building, welfare check-ins, specific subject matter education, and refresher training for the sort of safety bundles that we should be using to put in checks and balances to avoid interventional procedure related incidents. This pattern of incidents and events did not just affect Northampton General Hospital. There was an increase in similar events across the region, and Nhs EI have been taken our thematic approach based on the York classification of human factors very much to heart, and are asking the trust to work with them and the academic health sciences network of the region to apply the same approach more broadly, and that is being led on behalf of the trust by the Deputy Director of Governance. So once again, my apologies that the member of staff was not able to be with us today, and for my inevitably second-hand relaying of what he might have wished to talk to us about.
Okay, thank you for that. I think there's a reference to this in the Chief Exec's report as well, so we will come back to that. We'll also be able to talk about it in the afternoon meeting. Okay, on the chairman's report, I have a short video, assuming whoever's doing it can make that happen. Delighted to say that we, Northampton General, won the National Health and Wellbeing Employer of the Year Award. I think it was only the night before last, actually. So a national winner, and the award, the presentation of the awards is subject to a short video. So whatever else we're doing, we seem to be doing something right compared to all other trusts in the country in health and wellbeing. On you go.
To present this award, I'm delighted to hand over to Prerna Issa, Chief People Officer at NHS England and Improvement. It's all yours, Prerna.
Thank you, Candice. I am so pleased to have been invited again to the Our Health Heroes Awards and to present an award I feel so passionately about. The focus on health and well-being is crucial for all employers and staff, now so more than ever with the additional challenges faced by our NHS people during the pandemic. And it is a key focus within our NHS People Plan. This award recognizes those who are going above and beyond to implement well-being strategies that are making a real difference to staff and will hopefully inspire other organizations to do the same. So it is time to announce the winner. The Our Health Heroes Award for Health and Wellbeing Employer of the Year goes to Northampton General Hospital NHS Trust. A huge congratulations.
Okay, thank you very much. Very impressive. Mr. Smith, do you have anything to add to that, Chief People Officer, apart from just basking in reflected glory?
Thank you very much, Alan, and for sharing the video and Kevin putting it together. So no, I don't want to steal too much of Perena's thunder, obviously. I was going to show the actual award. We have it here. It's we have it now. So the only thing I just wanted to say, and I'm not so good at award ceremonies, and you know my sports teams, I'm not very used to seeing them either. But there is some thank yous that I'd just like to make quickly. I know we may be pressed for time, but I just wanted to thank Claire Hallis and Claire Brown, Moya, Robin, Anne-Marie, and of course all led by Bronwyn. It was really a poignant moment for us to receive this award on Tuesday evening, which was the 23rd of March, which we noted was a day of reflection, and it enabled the team, if nothing else, half an hour just to reflect on all of the work that we've put in place over this last year. And of course, we'll be talking about our people plan later, but thank you.
Yeah, thank you for that. And there is a strong theme through this agenda about people as well. So we'll be coming back to the people plan as the final sign off for that, which has been through all the necessary processes and committees. Anybody else want to say anything about that, apart from sort of smiles and well done, Mark? Good, thank you very much. Simon, Chief Exec's report.
Thanks. Morning, everybody.
Oh, sorry. Can you hold on? I've got John Archer-Jones' hand up. Can I just go back, John?
Thank you. Now, I just wondered how the award was scored. Was it a vote by employees, by staff, or did somebody do an assessment?
Mark?
Yes, so thank you, John. No, it's a submission that we made, given basically an outline of all of all the things we've implemented in this last year, and then there's a panel of experts externally that review our submissions and then make an assessment on that basis. And if I'm totally honest with you, John, one of the reasons why we're so proud to win this award is because the NHS in totality this year has really picked up its game, if you like, in relation to health and wellbeing. So to win it this year of all years is really, really special to us. And those on the People Committee hopefully will know that I can barely fit our health and wellbeing activities on the slide deck anymore. So that perhaps is the way, but it's a panel of experts. It's done externally.
Excellent. Thanks, Mark.
And you're muted.
Sorry about that. Yes, as chair of the People Committee, I just wanted to acknowledge what a fantastic recognition this is. I mean, if you're going to be recognised for something, to be recognised for looking after the health and well-being of your staff, I think it doesn't get any better than that. And I'm confident this is going to be the first of many to come. So well done, Mark, and your team. It's fantastic. Very proud.
Okay, thank you very much, everybody. I'm sure we all share in that last sentiment. Simon, back to you.
Thanks, Alan. Morning, everybody. I'm just going to focus on particularly one item in my report today. It's the Quality Summit, because it links fairly directly into the majority of the agenda items that we will spend time considering today. I want, first of all, to pay tribute to the work that was done in both the preparation and also the leadership of the Quality Summit on the day. It was, and a number of us were there, a thoughtful, reflective, insightful event in which people contributed honestly and fully about the difficulties that they face at the front line. And we owe it to them to reflect that in our conversations today. I'd particularly like to thank Matt and team for all the work that they did to get ready and to make that event such a success. Indeed, shortly after that event, I had a letter from our CQC relationship manager. And while she pointed out that obviously it's never great to have never events, what she was really impressed by was the honesty and reflexivity of the conversation that we had. No issue was dodged, and people spoke about how they felt as human beings, about what they thought needed to be done, about the impact that the incidents had had on them personally and professionally. And I think Bronwyn put it well when she said near the end of the event, and as we look forward to the launch of our new values, that was the truest exposition of a courageous conversation and living our new values that should seem. Others may wish to comment because I know non-exec colleagues were there. We obviously spent some time talking about, so what does all this mean for the organisation? What's the bigger picture here beyond the instance? And probably it was summed up by Jono, our intensive care lead, when he said, you know, the biggest impact here, because I asked what's the message I could convey to the board. And he said the biggest thing that you could say is take care of the people. You know, we're about to go into a very sustained period of elective recovery, probably a multi-year period. We haven't had waiting lists as long as the ones that we're now facing for as a country for many, many years. And he said, please convey to the board that we can't simply start again as though nothing had happened. You know, you need to take care of us if we're going to do what you need us to do. And so I wanted to convey that message, if none other, today, because we're talking today about our staff survey results, about our people plan. And therefore I wanted to quite consciously link for colleagues, in colleagues' minds, that that was the message that staff who attended that day wanted me to convey, and I would like us to hold in our minds as we go into the debate around our people plan and all that it means, because we have to make that people plan really live for people and really connect to them in a way that is meaningful to the work that they do for us so well every day. So I'm going to leave it there. Thanks to everybody who made that day. I've been to many quality summits, and I can honestly say it was one of the better ones I have been to. And so really well done to everybody who organised it and made it happen. And please hear the message from our staff who want us to think about the people plan and taking care of our people as we go into recovery. But I would also invite colleagues, if they would like to, who were there on the day, to comment in support or addition to the things I've said. I'll leave it there, Alan. Thank you very much.
Okay, thank you, Simon. There clearly is a thread between the Health and Wellbeing Award Tuesday night that you've just seen and the need for staff to be looked after. The academic evidence behind, if you look after the staff, they will look after your patients, is stronger by the day. So I open it up for comments. Perhaps I could go to Tom first, and as chair of the quality committee. I know you were there on the day as well, Tom. So
yeah,
comments, please.
Yeah, thanks, Alan, and I suspect Jill, whose hand was up first, may say the same as me, as my colleague on quality governance, and who was also there. I think the first thing to say is that these events were brought to our attention at quality governance immediately that they happened, through a direct phone call from the medical director, and then straight on to the next committee meeting. So I think from the start there was an openness and transparency about the reporting of these events, and we've been kept regularly updated. I would echo Simon's comments. I think the Quality Summit was extremely good, and we've had very positive feedback both internally and externally after that. And I think it was good because the environment was such that people felt able to have a very open discussion about things that went not so well, and able to discuss ways in which there could be a change to ensure that that didn't happen again. And we're clearly aware of the impact on patients and their relatives, as well as on staff. And I think there was a real sense of all aspects of the community coming together, which I think shows a positive environment in the organisation, which clearly will be positive for the future experience of our patients and their relatives. Jill, I don't know if there's more that you want to add to that.
Jill?
Thank you. Yes, clearly want to echo everything that Simon and Tom have said. What struck me in addition was that there were absolutely no excuses. So the presentations were made by clinicians who explained what had happened and what they'd done following the incident to prevent recurrence. And indeed, we've been monitoring an action plan through quality governance. But nobody, not one person, mentioned the context of COVID and how difficult it had been. Staff had been deployed into different areas they weren't used to working in, sickness rates, staff shielding, the additional use of extra PPE in certain areas. Nobody mentioned that. Nobody made any excuses. All they said was, this happened, we don't want it to ever happen again, and this is what we're doing to prevent recurrence. And I think that was particularly impressive.
Thank you. Any other comments from anybody at all on this? It's been a long thread now for not quite a decade of trying to change the NHS's attitude to incidents when things go wrong, to get something closer to that of the airline industry. I'm sure many people remember the previous Secretary of State making it a major priority. And so there's a couple of rules about this, really. One is you don't use it to discipline or blame anybody. The other is you don't keep it a secret, you tell everybody. And the third is that in doing that, you make sure that the lessons learned are very broadly disseminated. So bearing in mind that the Quality Summit had about 150 people at it, I think we can be reasonably confident that they were broadly disseminated. And given what everybody is saying, we can be very confident that people were not being secretive, they were not hiding anything, and they were certainly not regarding this as an exercise in protection, but rather more an exercise in making sure all the lessons were learned. So thank you for that. Thank you, Simon. Is there anything else on Simon's report anybody wants to pick up at all? Because he does cover a number of topics in that report. No, I'm not seeing any hands up for that. Aileen, welcome as our interim hospital chief executive, and I don't think you quite managed, and I know you had IT difficulties over the last few days, but I'm glad to see you. And your hospital chief exec's report, please, and then particularly focusing on the 52 weeks trajectory, and then we'll go into the integrated performance report as well, which you lead on. Thank you, Aileen.
Thanks very much, Alan. So not to repeat everything that's already been said, but firstly, it's great to be here, and this is my first report. I wanted to put in some detail around some of the numbers we are talking about in terms of the waits we've now got for treatment in the hospital. And that's not to scare anybody, particularly any of our staff, because we do have some significant waits now, and we do need to try and pull them back in a planned, calm, orderly fashion. I'm very conscious that although we are, unfortunately, and I'm pleased to say, coming out the other side of the latest wave of COVID, we've got really minimal numbers in the hospital now. Nevertheless, it's been a long year. People are very tired, as everybody said, and we really must look after our staff because these will be the same people that we're asking to try and work through our backlogs. So just the numbers are, as I say, are not to panic anybody, but we will, and Joe will go into a little bit more detail in the IGR, but over the coming months, we will have a plan as to how we pull down some of these waits for treatment, because it's not just 52 weeks, it's also in some of our diagnostic modalities as well. So it's great that we're coming out the other side of COVID. I think everybody is trepidatious about, will we stay out of it? Because we're all coming out of lockdown and we're seeing slight numbers in terms of rising in the community. But the most important thing really is that we have a plan. We have a plan that is not a knee-jerk reaction plan. It will take time, as Simon has said, to work through. It's not just about, from my perspective, about taking the longest waiters and just picking people up as they tip over the edge. It will be about trying to create a break really in those queues. So there's lots of work to be done. We will be working with clinical teams to figure out the best way of doing this so that we are doing it in an orderly, planned, calm fashion, because we also need to start planning for next winter, dare I say it, because we don't want that to come up and take us by surprise. So all of that detail will start to come out over the next month or two as we work that up. And not wishing to be outdone by Mark, just to say that NGH on Monday night, I virtually went along to the council meeting, and NGH was awarded the honorary Freedom of the Borough in recognition of all the hard work of the staff. So we will obviously let everybody know about it. It has been in the papers, but I think it's yet another example of the recognition for the organisation, our staff, how hard they've worked from our local community and councils. So that's I'll end on that because that's a really nice piece of news. Thanks, Anne.
Thank you, Aileen. Anybody have any comments on that? So I changed my view there. No, thank you. Okay, and straight into the integrated governance report, please. Somebody got it? Somebody doing the...
Joe is definitely next door. You there, Joe?
Joe? Somebody help.
Yeah. Do you want me to start on the performance section?
I don't know. Aileen's in charge of this bit, so if you could just make the flow happen, Aileen, that would be good.
Joe, can we start with the performance and then we'll go on to the other sections? Thanks.
Yeah, that's fine. Okay. Okay, I'll start off with A&E performance, which was 73.7% for February, which was clearly an improvement on January, but obviously not where we want it to be. I just need the board to note the high number of ambulance conveyances that we saw in February, which was 2934, which was a massive increase on what we've seen for the period same period last year. And I'd also like everyone to note the conversion rate of conveyances, which was higher than normal as well, clearly reflecting the COVID wave and winter. So as Eileen said, we do need to start preparing for the next wave of COVID and winter and what that's going to bring. In terms of cancer performance, we had quite a detailed debate about this at the Quality Committee. Obviously, performance is not where we want it to be. January does generally see a dip in performance as patients will choose not to have treatment in December and over the Christmas period. But I think as Matt made a good point at the Quality Committee about the legacy patient number, which is clearly massively improved from where it was. And that's really a good marker of where we are currently. And I'm sure Matt will come in and say something about that. I think what we should note, though, is that our tertiary centres are seeing delays in terms of diagnostics. and specialist diagnostics, with which our patients will be going to our tertiary centres for. And we are now being asked by tertiary centres to help them with their backlogs. So I don't think we should underestimate the challenge within the cancer backlogs across the region either. In terms of RTT, the median wait is 10.5 weeks. This is new to me, coming from Kettering, as we weren't on this pilot standard. What I would say is the good news is that we've started elective activity again, reopening the theatres that we said we would in March, which is great news, and outpatient activity has been restored. I've met with all the divisional directors and divisional managers on the trajectory, as Eileen has mentioned. We currently have 789 patients over 52 weeks and 989 who are over 45 weeks. So I'm certainly not underestimating the challenge that is definitely ahead of us, which is quite stark. The teams are very ambitious. They want to clear these backlogs, but I think we do need to be cognizant of our staff who are expecting to work with us on this and how we support them. And also, I don't know what I don't know in terms of COVID at the minute. And I do think we should be mindful that this is going to have a significant financial implication as well, as we will be doing waiting list initiatives and all other sorts of things to clear our backlogs. In terms of diagnostics, we're clearly not on the 1% standard. And as Eileen referenced earlier, we do have a quite significant backlog in terms of diagnostics. I've currently got 1,472 patients waiting for an echo, and 221 of those patients have waited over 13 weeks, which is quite significant. We also have 142 endoscopy patients that have waited over 13 weeks currently, although there are sparks and hopes in terms of MRI and CT, which are now booking well below 6 weeks. So we do have a draft plan that's coming together around diagnostic waits and how we can clear them and put in some sustainable capacity to keep diagnostics where we need it to be. Obviously happy to take any questions that anyone has.
Should we take questions? Oh, sorry.
John, and then Jill. You're muted, John.
Thanks, Joe. Given that we know that patients arriving at A&E are much sicker than they have been in the past, and I think that's likely to go on for months, do we need to rethink how we manage in A&E, maybe in terms of staffing or even processes, given that this is going to go on, I would have thought, for months, if not a year or more, and whether, you know, whether the current setup is appropriate to the sickness of the patients that are arriving?
Let's just hold that thought, and we'll go to Jill and then David and gather some thoughts, Jill, so you can answer them collectively. Jill and then David.
Thank you, Chair. I was going to ask Joe about page 22 of the report, which looked at stroke patients spending at least 90% of their time on the stroke unit, because we're obviously a very long way from the national standard, which is obviously of concern. And I wondered what the plans were to get this back on track ASAP.
Okay, we'll come to that. David? You're still muted.
There we go. Apologies, Chair. Yeah, the first question was the one that usually comes up at this meeting. It's about the independent sector. How are we doing with regard to the 3 shires? The second one was a similar comment to the one that John made. Actually, it's interesting to note that, you know, A&E attendances have gone down by 30%, but ambulance arrivals have gone up by 45%. Now that's a huge disparity from where we were, and I just wondered what the thoughts were about the underlying reasons for that and when that was going to change around. The third point I would make is about RTT, and we did discuss this yesterday at our group finance and performance committee, and it is about RTT, it is about 52 weeks. It is about the fact that 52 weeks is just a point in time, and that what we really need to see is a profile, because there must be a hump behind that which is coming. And I think it'd be very important for the board to understand the trajectory and, you know, how we intend to get 52 weeks down to where it should be, which is 0.
Yeah, I'm sure Joe can talk about that. She did mention the 45-week number, of course, which was also pretty scary. But anyway, Joe, well, three or four good points there. Do you want to respond?
Yeah, so just regarding John's first question about A&E, I went down to spend some time with Tristan Dyer, who's the clinical director in A&E and urgent care. He walked me through the pathways and the processes, and he's looking at changing some of those to deal actually with the number of ambulance conveyances. So for example, last week they started with a pilot on a new flow nurse who streams the ambulance conveyances that comes through the door. I think we should note that we're still discharging around 50% of our ambulance conveyances. So they're not all acutely unwell, those that come in via ambulance. So definitely we need to look at the processes in A&E and the flow in A&E. And one of the other key focuses of Tristan is to look at that flow into same-day emergency care. And also we're looking at other things such as surgical assessment units for NGH, which have existed before, but haven't worked so well in the last few years, and processes have kind of fallen by the wayside. So we'll be looking at different things over the next coming weeks as we want to improve the flow in A&E, and we want to improve the process in A&E as well. And what I would say is they're a very, very committed team. And I was quite impressed, really, we're very impressed with how Tristan taught me through the pathways and his knowledge and his detail around the pathways as well. In terms of stroke, I'd look to Sharon and Matt to come in with some more detail around this, but what I would say is that flow has been very compromised over the last 6 weeks in particular, and since I've come, flow's been a daily problem. The number of stranded patients has gone up. It's compromising flow in and out of the stroke unit, and also the physical layout of the stroke unit is an issue, and I went to see that for myself last week in A&E. So we know the stroke metric isn't where it needs to be, and I have met with the team around how we improve that as well, Jill. So I'll be looking at how we improve the processes around that over the next coming weeks. And obviously Sharon and Matt, please come in because you know a lot more of the past detail on this than I do. In terms of ED conveyances, Eileen and I do meet regularly with EMAS. I meet almost daily with some of the EMAS team as well. What we're going to do is look at a couple of audit days where someone independent from NHSI is going to come in and do an audit of ambulance conveyances with the team. And they're going to look at those conveyances that are discharged, why they're discharged, and what alternative pathways we need to put in place for those conveyances. Some of this will be picked up in the ICAM work, the integrated care programme that I know you all know about in terms of those patients not coming to hospital. Some patients clearly do need to come to hospital that are discharged if they've broken a limb or just need to be checked out. So we'll be looking at all of those, streaming direct into SDEC or streaming into Springfield, which I went to see last week as well. And then the last question around RTT and use of the independent sector. We have continued to use the independent sector, but I think we need to relook at that again, because we will need more capacity. And of course, the independent sector have got their own waiting list to clear as well. So we do need to be mindful of that. But we obviously do need to work in partnership with them, and that will be a focus over the coming weeks in terms of our plan. As I said, the numbers are quite stark. There's 989 over 45 weeks, and there's 1,045 over 40 weeks. So there's quite a big backlog that is sitting between 40 and 52 weeks plus at the moment. Below that, the profile is better, but what I'm trying to do with the team at the minute is get underneath that. So next week, I've got Rob Haywood coming over from KGH, and he's going to do a confirm and challenge session with our RTT team to check that our PTLs are completely clean, are validated, are what we say they are, and have had all the rules applied that they should have had applied. And then we'll look at the profile of the waiting list. That will come up in the elective recovery report that we're going to come on to in a bit, and match that against our trajectories, our capacity, and what we're also looking at is our sustainable capacity as well. So I hope I've answered all the questions, and I know that Matt's got his hand up to come in as well.
Sorry, we'll go to Matt in a minute, but it is worth saying, Joe, that's pretty impressive set of knowledge after 25 days. Well done. Matt.
Thank you, Chair. Just to come in as suggested by Joe on a couple of points. So in relation to time that patients with stroke spend on dedicated stroke units, inevitably the peak of COVID with over 250 COVID positive patients at worst in our beds, and the need to protect our stroke patients from the risk of hospital-acquired COVID during that time has meant that we have, and that applies to other groups of specialty medicine also, we've had to do a fair amount of changing of ward designations such that they are red wards, amber wards and green wards rather than specialty specific. And so, for example, many of our stroke patients were co-located with cardiac patients so that while they were suffering their acute cardiovascular event and we were treating for it, we weren't exposing them to unnecessary risk of COVID. We would therefore expect a significant and sharp recovery of that position in the relatively near term, now that as we speak, there are only 19 inpatients with COVID diagnosis in our beds at present. Alongside that, Joe and I share a view that although we provide excellent stroke care at this hospital, as recognised by our SNAP rating of A, which we've held for some time, that we the physical space on the acute stroke ward is suboptimal for patients recovering from stroke, and indeed the staff. And there is a piece of work that the senior leadership team of the organisation is looking at in how we can reuse the old HDU and ITU space when the new build is completed, and providing better space for our stroke patients is on the list of things that we are considering in that point. In relation to the cancer legacy that Joe asked me to comment on, she's completely agree with her that while you are in a recovery phase, while you are clearing a backlog of patients on a stroke on a cancer pathway, then inevitably performance will fluctuate if you are treating patients in time order and in accordance with their clinical priority. And the only reliable indicator in a recovery phase is the number of patients in your legacy backlog, if you're doing things properly. And that has indeed come down very significantly, thanks to the work of Joe and her team, and also Hemant Namadi driving it down. Thank you.
Sharon and then Simon.
Thank you, Alan. So my comments that I was going to make around infection prevention and the space opportunity that we are presented with shortly has already been made by Matt. But equally, I think we have a further opportunity to look at our workforce and see how we can get those to work differently, particularly around the integration more of our therapies and our nursing workforce, along with our medical colleagues. And I think that should also enable a better flow of patients through the system.
Thank you. Simon.
We meet at an interesting moment as ever, because I would be expecting either today or tomorrow the NHS Planning Guidance as a whole to be issued. And so the first thing I would say is, as we meet on the cusp of that, I would strongly encourage colleagues to read that guidance as soon as possible. It will make clear that we face an unparalleled set of challenges that we haven't seen, as I was making clear in my comments, for probably 15 or so years in terms of the size of the recovery challenge that we face. It follows from the size of that challenge, it will be a multi-year effort to get us back to a position that we were pre-COVID. And it follows from that multi-year effort that we're going to have to think quite strategically about things that we prioritise for recovery in the year ahead. So one of the things I would be suggesting to the board is that next time we meet, which will obviously be in May, we have a conversation about what is that recovery strategy, so we are clear, because it's the duty of the board to hold a strategic view on these matters and to be clear how it interprets the planning guidance in the context of setting its priorities. There are a couple of things that I think colleagues have mentioned that I think are worth touching on. The first is what's been referred to as bounce back. So we know that activity this year has been depressed. Referrals have dropped for all the reasons that I don't need to rehearse here. So one thing that we are going to need to think about as we go into recovery is to what extent do we plan for that work to come back into the NHS, that work which has been depressed in terms of demand. The other is in terms of treating backlog. So there's an old rule when you do this kind of stuff, backlog is backlog. You have to work out a plan to deal with that separately. And you have to then keep on top of business as usual work, the new referrals coming in. So one test of our strategy will be to what extent is that being done. And then I'd remind people that the planning guidance will also make reference for the need to take care of people. So on the one hand, we've got to go as fast as we can to support our patients by recovering back the position that we inherit at the end of March. On the other, we also need to challenge ourselves, are we going too fast in terms of our people and just pushing people beyond what is reasonable that they do? And so the debate I would like us to have in May is that strategy with those imperatives. How do we satisfy ourselves that we are doing the best that we can? But how do we also satisfy ourselves that we're doing the best we can by our people?
Thank you, Simon. It's a cracking question for a board to think its way through what the balance of that is. And that's obviously going to be happening over the next couple of months. So as soon as the planning guidance comes out, which should be approved today at the NHS England board, and then some very weighty, complex documents that sit behind it will also start to flow. Anyway, those will all come out to you, and we need to think very carefully about that through the next couple of months, culminating in the public meeting in May. Anything else on that? No. Okay, who's next, Aileen?
It will be Matt, please, with Medical Director's report.
Thank you, Eileen. Thank you, Chair. We've clearly touched upon the quality summit at some length already, and whilst, as has already been said, whilst these things we would never wish them to happen, I'm grateful for the comments in relation to the response that we've made, and actually reasonably excited that the Academic Health Sciences Network and NHSEI want to adopt our approach and work with us to roll that out across the region. In this current tale of COVID, we're starting to resume a fair amount of the normal corporate medical portfolio activities that were paused in order to allow the team to support the front line better. And the particular issues that I wish to highlight to the board today, we're delighted to announce the appointment of Dr. Tom Evans as the Associate Medical Director for Primary Care Engagement. So Tom is a local GP who has over many years worked in our emergency department and urgent care as a registrar grade also, and will continue to do so. He has an interest in education and development with his connection to the University of Buckingham, and a very key item in his portfolio, working closely with Joe and myself, will be to progress at pace some of the ICANN work and be able to unpick some of the interface issues between the various different providers in the system, which will be really helpful. So a warm welcome to Tom Evans. We are making really good progress with our joint academic strategy for the group. In addition to this board will know that both boards have approved the strategy. I'm now in the happy position of being able to advise that both finance committees have endorsed the 5-year business cases. And in terms of the return on investment, year one income target has already been exceeded, given that we only approved the strategies and business cases in the last couple of months. That's a pretty reasonable delivery. In terms of keeping patients safe, the deteriorating patient work stream has, as we are coming out of COVID, gone live. To be really succinct about that, this is where a patient whose deterioration is identified through their national early warning score elevation, a series of comprehensive responses that attend to all the different elements of why a patient could be poorly and what we need to do about it, is supported and indeed mandated through the iBox system on the electronic whiteboards. And the patient safety team are supporting the embedding of this across the organisation as we speak. I have nothing specific else to raise, but I'm happy to take any questions. Thank you.
Okay, any comment? Where are we? Tom?
Yeah, thanks, Matt, and thanks, Chair. Chair, I just felt from a Quality Governance Committee point of view, we also wanted to highlight an item that we discussed in our February meeting that just falls within the Medical Director's portfolio, and that related to the annual research report for the institution. And as we know, engagement in research is another way of improving quality of care and outcomes. And I think it's really important to note that the 2021 year saw a 200% increase in our patient recruitment to NIHR portfolio studies. And indeed, the Trust was one of the top 10 recruiters in the country to the recovery trial, which, as we know, has made a step change in how we manage patients with COVID in terms of reducing their ICU admissions and mortality and serious complications. So I think it's again really important to note that, and the Quality Governance Committee were keen that the public board were aware of that.
Thank you. Yeah, it's not only very important, it's quite an achievement as well for a trust like Northampton to be in the top 10 recruiters. But that's a place they are in a number of studies historically, so they've got a great track record in this. Anything else at all on that? No. Okay, who's next?
Move on to Sharon, please, from Director of Nursing's report. Thank you.
Thank you very much, Eileen. So just picking up some of the highlights from the notes within the board papers. So firstly, we've continued to measure our patient feedback, our patient satisfaction scores. The Friends and Family test was recommenced nationally on the 1st of December. Although we haven't been able to use paper feedback, we have used SMS text messaging and automated calls. And I'm pleased to report to the board that our inpatient and day case satisfaction scores have remained between 90 and 95%, which is within normal variation. We're going to be reconvening our patient experience group within the next 4 weeks, and in which at that meeting we'll be looking at what we need to prioritise on our work plan going forward. Clearly within my portfolio, the COVID response has remained a high priority for us. And as we've already heard from the Medical Director, at the peak of the pandemic in February, we had 259 positive patients in the organisation. And as of this morning, we only have 19. That's taken a huge amount of effort from our IPC team to make sure that we get the leadership and support across the organisation. We've been working with our board assurance framework to make sure that we're making the progress that we need to, and we've made step change improvements with our PPE compliance rates and the provision of our domestic support as well. We have had 2 COVID outbreaks reported during this period on Abingdon and Collintry B wards. Root cause analyses have been undertaken, lessons have been learnt and put into action. I also just need to flag up to the board's attention that we have had an outbreak of CPE within our critical care unit. We had 9 patients identified that was isolating the same organism. For those members of the board that really are not familiar with CPE, it's a bug that lives in the gut. The majority of the time it's harmless with no signs and symptoms. However, if those organisms get into other parts of the body, they can cause infection. And it's a really difficult organism to treat as it's resistant to so many antibiotics. We're doing a lot of work in terms of managing the outbreak there. We have 3 cases remaining within the, 1 positive case in the organisation and 2 contacts who are being isolated. and we've had no further cases since the 9 of the outbreak. Thank you.
Okay, thank you. I'm not seeing. Oh, yes, sorry, hands were flashing there. Yeah, sorry, Rachel and then David.
Yeah, question, Sharon, around complaints. I notice quite understandably that the timeframe has been revised to a maximum of 6 months. Are we comfortable that we've got a handle on those coming through and our responses, or do you think we're storing up a problem further down the line?
No, I don't think we're storing up a problem. We've got a very proactive complaints team, and I think that by the mere fact that we agreed to extend it slightly has given them the breathing space they require to make sure we're able to do the thorough investigations that are needed. So certainly not looking to extend it any further where there's the opportunity to do so, and I don't believe that we're storing a problem up.
Claire, you and I had a conversation about complaints and a complaints review process. Can you just remind me when we're starting that?
Yeah, absolutely, Alan. One of the things that we are going to be doing is we're going to be putting in a complaints review panel that is going to initially be chaired by Alan as our chairman. That's going to be looking at how we manage our complaints, what the outcomes are, and what lessons we can learn going forward.
Thank you. And like most things, I'll be looking for a non-exec director to take over the chairmanship of that panel after a couple of meetings. So you can just think about that, please. David.
Yeah, thank you. Thank you, Chair. Just a very brief question, Sharon. We made a significant investment in international nurses. A large number of them came into the trust over the course of the past year. How are they faring, in these very difficult times? Have we managed to retain all the nurses we recruited? Have we managed to get over here all the nurses we expected to get over here?
Yes, and yes, immensely proud. Our current vacancy rate is sitting at 1.67%, and that's been really contributed to by the overseas nurses that have wanted to come and join us here at NGH, and associated with our recruitment, our turnover rate is equally good. At the last people board, we had some international nurses talk to the people board about their experiences, the reasons why they come, etc. Lots of really good learning, and actually what we have in the organisation now is our international nurses have set up their shared governance council where they're able to articulate, support each other, and are actually want to play an active role in further recruitment into the trust.
Thank you, Sharon. That vacancy rate is really quite remarkably low compared to the NHS norms. Okay, nobody else? No, who's next?
We'll move on to the finance report, please, from Vola.
Thank you, Eileen. Thank you, Chair. We ended the month with a small surplus of 40,000, which maintains the year-to-date position at near break-even, in line with our forecast. This position was achieved after accounting for system support funding, which we offset by annual leave accrual. In February, we saw a reduction in the pay and non-pay spend run rate as a result of the reduction in elective work due to theatre closures. Agency spend remains at 1.5 million, which is similar to recent months, to cover staff sickness and self-isolation. In terms of capital, at the end of February, we spent 22 million, with a further commitment to bring our total spend for the year to 36.6 million. This will be 5.6 million short of our capital plan, and that slippage relates to our critical care unit, which, as we previously reported, was due to finding asbestos as we dug the ground. We've been discussing this with NHS EI, and in particular, wanting some assurance about needing the increase in our capital limit for 21-22. I'm pleased to report that in our just confirmed capital allocations for 2021-22, we've been allocated at least 4 million towards this slippage. We will continue to have discussions with NHS EI to ensure that we receive the full amount. The cash balance at the end of the month was 37.5 million, which is in line with previous months. But again, as we've noted in the past, you will recall that we've received a 1 month in advance funding, which NHSI will be taking away as from April. But again, we'll continue to monitor and manage the cash flow position of the trust to ensure our staff and suppliers are paid. In terms of our forecast, our I&E forecast for 2021, we're working through and we expect to meet our forecast break-even position. I would also like to take this opportunity to just talk very briefly about 2021-22. As we know, this year has been unprecedented, and in a normal year, we will be coming to the board for approving a draft budget for 21-22. As Alan and Simon mentioned earlier, we're awaiting the planning guidance any time from now. But what we know is that we've been told that we should expect to be funded for the first half of 21-22 on similar basis as we have been this year, which is block funding and top-up arrangement. And we also understand that system plans, financial plans are due to be submitted by the 6th of May. In the meantime, what we have been doing is working with our divisions to develop an expenditure budget, and we will develop this following the receipt of the operational planning guidance, and we'll work up all the activity, workforce, and financial plans, recognizing the elective backlog recovery work that we've talked about earlier that needs to be done to ensure we're providing the best care for our patients. And we expect to bring this back to the board next time. We continue to work with our system partners, and we are developing a 3-year financial plan. I will stop there and take any questions. Thank you.
Okay, I know this was talked about a lot at the Finance Committee yesterday. I don't think there's any hands up for this one. We seem to be pretty well on track this year, and of course next year we're waiting the planning guidance to see what the requirement is, what the ask is, and what the allocation is. So thank you, Bola. And I'm guessing it's Chief People Officer next to finish off.
Yes, by process of elimination. Thank you very much, Chairman. And it's always the issue when you go last that lots of the points have already been covered. So in terms of the vacancy and turnover rate, as Sharon mentioned, we've been doing some fantastic work on closing that gap and really bringing that rate down over the course of this year, despite all the pressures and situations we're under. But what Sharon will also underplay is she's leading a very key piece of work across our whole system on international nurse recruitment, and that's for ourselves in Northampton, Kettering and NHFT. And if we manage to achieve that over the next 18-month period, we will not just see ourselves okay for the short term, but obviously medium and long term whilst we wait for the increased number of students which are coming forward for healthcare positions in universities, which is really encouraging news too. That being said, with the closing vacancy rate, you'd then expect to say, okay, so the agency spend should be coming down then, Chief People Person. What's happening there? Why is there a difference between the two? And if that's not a question that David and John were going to ask, I'm sure they will very shortly. And of course, then Joe's mentioned that in terms of the elective work that we're undertaking and the increase that we need to increase our capacity, if you like, to ensure that we can bring those elective targets or those elective positions back in line or indeed below where their target is. So whilst turnover and vacancy rates are low, and that's great and encouraging, we will not be taking our eye off the ball in relation to those, as articulated also in the people plan coming later. From a sickness position, we saw a January increase in our sickness, which again is obviously in line with the COVID position and the more prevalence of the virus in the community. We didn't see a sharper rise in our county as other areas within our region did, and therefore we are equally not seeing a significant drop like other areas within our region are. So we're continuing to work on that, and of course the Health and Wellbeing Award and the activities that are undertaken demonstrate that. But we really need to continue to look over the next couple of months, particularly how we start to bring our clinically extremely vulnerable colleagues back into the workplace, and then that will not be on the 1st of April. Everybody returns to work. We're having continuous conversations, dialogues, and looking at appropriate avenues for those colleagues, including risk assessment in all areas. So, but we are continuing to be concerned about sickness absence and particularly so our colleagues' mental health, and we're looking into that too, which again is another part of people, and I won't steal that thunder now. In terms of appraisal and education, we know, given the position we've been in, that these targets have been strained in order to be achieved, but we are putting plans in place as such with appraisal lights, and indeed in terms of education, we're looking at our e-learning modules to make them more straightforward for colleagues. That's going to be really important. And the one thing that I also wanted to reference here was, not that we would have forgotten, but of course we are the lead employer from Northampton General in terms of the vaccination centre. And I just wanted to pay tribute to my teams both in Northampton and indeed Kettering in supporting me with that huge programme, because that is a roster of the best part of 600 people that are working through that vaccination centre, obviously on temporary, voluntary, etc. basis, to undertake the vaccination programme within the county. The metrics reviewed in line with the people plan will mean that our future integrated performance report will look slightly different in terms of what we choose we want to focus our attention on over the coming months. But they are all the messages that I wish to convey at this point, but happy to take any questions.
Okay, Denise, well, I lost it. Denise and then Rachel.
Thanks, Chair. Yeah, Mark, I just wanted to check, do we have any statistics in terms of the rate of staff vaccinations?
Hi Denise, yes we do. Let me just flick my book back to when I last took that data set on Tuesday morning. I have them here. So we have in Northampton, so we have 85% of our substantive colleagues have received the first dose of vaccination. When we include our bank colleagues, of which there are many, and obviously they work part-time or they very sporadic in their appointments, that we have, that's 72%. I should have also reported, you were right to remind me, that we have started to give second doses of the vaccine from the 8th of March. And so those numbers will also be keeping a close eye on. We do talk about these every week in our system meeting on a Tuesday morning in terms of our position, NHFT, KGH, and so on and so forth. One of our is slightly less of an issue here, if I'm honest, in NGH, is the first dose now availability. We are giving second doses of the Pfizer vaccine. First dose availability is in the vaccination centre. So we're asking colleagues to go to the vaccination centre, which is geographically located relatively close to this organisation. So it's not too much of an issue for colleagues, but we are finding that to be an issue. We do, and we would prefer, and Rachel, our chief pharmacist, is aware of this, that the more AstraZeneca first dose we can get on sites, the more as a flu campaign type approach we can run in terms of our vaccination program, and therefore conduct more first doses. But we have had conversations, we have written to all of those colleagues that have yet to receive a vaccination or come forward for one, conversations and as I say, documentation has been with them to encourage them to undertake and receive that vaccination.
Okay, that's great. Thanks very much, Mark. Thank you.
Rachel.
Mark, just on the subject of well-being, do we have a way of measuring it? It's quite a subjective thing, isn't it? So I was wondering how we capture that and track any progress.
Thanks, Rachel. Yeah, there's lots and lots of data sets that we look at. Obviously, we look at reason for absence, and therefore we tailor our well-being to affect that. But we also are now looking more in terms of our psychological support. So we've gone into a collaboration with our charity, so Northamptonshire Healthcare Charity, NHFT, ourselves, and KGH in terms of a Stronger Together hub, where we can give people quicker, more speedy access to mental health provision. And we are looking at those statistics too. So where is it that people are coming forward? Our teams coming forward, is it hitting the mark or not? Is it delivering what people need it to do? So there are many different ways of testing out many of the different strands of health and wellbeing we have in there. We do have user feedback, so we have been running the SOS sessions and continue to do so, which I've reported previously. But in the last 3 weeks, we've also been working intensely with our theatre staff, acknowledging that a lot of them had been redeployed into different teams and working in ITU, and are now coming back into the theatre environment, as we've discussed today, in terms of some of that elective work and reteaming. It's not a great phrase, but in terms of reteaming and reintegrating back into that environment. So there's lots of interventions that we have, and at the moment we have qualitative data in terms of some of that feedback, but we're trying to work on more of the quantitative stuff.
David.
Yeah, thank you very much, Chair. A commitment was made to perform 100% risk assessments on BAME staff a number of months ago. I did see a news item earlier today concerning the fact that these had not been done or had not been followed up on in many cases around the NHS, around the system. What is the case at Northampton General Hospital, Mark?
Oh, so we most definitely have undertaken them. The 100 is very difficult to achieve on the basis that people move, and we have to keep trying to track them down. I can find the figure over the next hour, but it was in 99%. It's really, really high in terms of the risk assessments undertaken, and indeed that follow-up. It's the reason why it never quite stays at 100 for a long time is because we have new people coming in and people leaving, which fluctuates the position. But it's very, very high, David, and I can get the exact position for you.
Thank you.
Okay, everyone. Thank you very much. I'm assuming that's a legacy hand, Rachel. Fine, thank you. Nothing covering any of that. No. Okay, straight on to the elective recovery challenge. Joe.
Just trying to unmute myself. Right, Andy's going to drive the slides for me. So Andy, Faye and myself have put together this presentation. Well, Andy has prepared the slides because he's really good at this, as opposed to me. So what this is covering today is an outline of the approach that we're going to take and the data we're going to use to track recovery. So we go on to the next slide, Andy. So as we've talked about today, obviously over the last 12 months, not just at NGH, but nationally, the patient tracking lists, or the PTLs as we call them, have grown considerably. We know our COVID numbers are coming down, and now we're starting to go into elective recovery. So there's three key strands to this. The first is ensuring that we understand our PTLs, as I referenced earlier today, and that we're confident with our PTLs. And we have been doing ongoing validation, so this isn't nothing new. There has been national approaches to this, and NGH have done a lot of this since last August, and as have KGH. So we're just doing some more validation so that we are completely assured that everything is accurate and up to date. And as I referenced, Rob, who's the head of access over at KGH, is going to come and do a confirm and challenge session with Tasneem, who's the head of access here at NGH. And they're just going to challenge each other to check that our data sets are correct and we've both followed the same rules that we should have done. The second is explore the avenues to clear the waiting list. And we'll come on to those in a bit more detail shortly. But again, this is part of our trajectory and our plans currently that we're putting together. And then lastly, how we'll monitor progress and monitor the decisions and actions that we take. Andy can talk a bit more about this in a bit, but we'll have a report that's available from tomorrow. Next slide, Andy. Thank you. So just going back to, in terms of understanding our PTLs. So we are now looking at that, our PTLs, the patients that have been treated have been discharged of the PTL. There isn't duplicate data entries on the PTL. That patients who have cancelled or DNA'd have had the appropriate process followed. Patients who've declined treatment, again, the appropriate process followed, which includes clinical conversations clearly with GPs and others. And as I said, the DNA patients have obviously been removed off the list as long as it's clinically safe to do so. Again, I've referenced the audits that have happened previously at KGH and NGH. The last one at KGH showed that KGH was better than most trusts, which is really good. And obviously, we just want to make sure that together we've got the same rules applied. We're working off the same clean, validated waiting list. And there's obviously a system conversation about a system PTL via the inpatients collaboration group. And there's lots and lots of discussion about that. It's not straightforward, but we started those conversations. Next slide, Andy. Okay, so in terms of the PTL, looking at the profile, and I referenced this earlier when I was talking about our profile over 40 weeks and then what was under 40 weeks. The first scenario is the model PTL, where the numbers of waiters reduce over time, which is clearly where we want to be, but we're not there currently. We're probably in scenario 3, sign of high concern with issues at 26 weeks plus, and obviously we've got a long tail of 52-week waiters currently. But obviously where we want to be is to get to the model PTL profile, but it is going to take us some time to get to there. Next slide, Andy. In terms of the avenues that we're exploring, Faye and I are having lots of conversations at the minute about how we can work together to clear some of our backlogs together, because clearly we have to do that together. And there are opportunities. Continuing to work with our IS partners, independent sector, is really critical, as I said earlier on today as well. We've at both sites got insourcing, so companies who are on site carrying out activity on site, both outpatient and inpatient day case work. The clinical validation of the PTL is clearly critical, but I would emphasise that is an ongoing daily routine. It's not just something that we'll do by the end of March and never do again. And included within that is also writing to all of our patients, because some of them have waited a long time and some of them may have sought treatment options at other providers. We'll obviously continue our internal validation programme, and we will monitor that through our reset weekly meetings as well. We are looking at theatre productivity and efficiency, taking account of the fact that the IPC, the infection control rules around COVID, have changed almost daily over the last year. So just to make sure that we have applied all the necessary rules that we should to increase our efficiency in theatres. We know there are opportunities within outpatients to increase optimisation. A lot of the clinicians here are talking about how they can do more virtual work and how we can enable them to do that, particularly with virtual working areas set up across outpatients that clinicians can have private conversations and can work better when they're here on site with the support that others can offer when they're on site. We're also looking at patient-initiated follow-up and the concept of that, which has worked well in other places. And we will have to do waiting list initiatives. And I did reference earlier that this will obviously have financial impact, but we will have to do it, and we will have to be working weekends and evenings. Again, I will emphasise the fact that we have to be cognizant of how we support our staff to do this. Obviously, all of these options will be explored at both sites, and again, we'll work together on that. In terms of monitoring progress, Andy may want to come in on some of this, but we have a lot of reports that we will use to monitor progress, and at both sites there is going to be a weekly recovery meeting. On this site, mine will be with the division directors, the divisional managers, the head of access, and our head of cancer services, and a few other key people, and we'll look at our recovery plan each week, exceptions, and how we unblock any problems that we come across. So we'll look at, within that, we'll also look at any other trends around COVID, wave 3 predictions, occupancy rates, and so on. And again, the profile of our waiting list in terms of P1, P2, P3, and P4, and other views across the system as well. Andy, is there anything you want to add at this point?
Only to say, I think, Joe, that this is a classic example of needing to use data to drive our actions. So what we'll see in different PTLs when we look at a speciality level will reveal different issues, and we'll need to take prioritized actions based on that. So what we plan is to have this weekly reporting that has the detail that actually allows people to drill down, that's consistent across both trusts, that we're able to keep driving that through. So and as Joe said, that will be available from tomorrow.
Thank you, Andy. And I guess in terms of next steps, as I've said, we'll have the validation completed, this current validation completed by the end of March, next week, sorry. The actions that we're going to take will be agreed by the end of next week. I will have my trajectory and my action plan ready by next week, and we'll have a monitoring report. What I would say is that, remember back in the not too distant past of September, when we started our previous elective reset, and we did really well. So we are battle worn probably in reset and elective recovery. We know what we need to do, but we do have to be mindful of how our staff feel. And we also have to be mindful of the next wave of COVID and the variants that we don't know anything about yet. So they may impact on what that will do to our plans. But we will start regularly reporting from May onwards. So I'm happy to take any questions anyone has.
Okay, thank you for that. That's very thorough stuff. And clearly, in the end of the day, this is This is a data tells you everything you need to know exercise. And it's pretty impressive stuff, and linked to the, relatively new legal duty of collaboration, let alone our desire to collaborate across the system with Kettering. It's also a significant improvement around the joint working and the opportunities that go with that. Denise and then Jill.
Thanks, Alan. Yeah, I just wanted to reiterate that that was a great report and reassuring, and it's really good to see the increased use of data. Just a quick question, you may have covered this, so apologies, Joe, if that's the case, but in terms of all of the review that you're doing, is there involvement from the people team, the people director as well? Because we keep talking about making sure that we're getting this balance. So will that be an integral member of the team?
Yeah, so I sat down with Bronwyn last week, I think it was, and we looked at some of the outputs from the staff survey, some of the issues that we know that we've got in terms of where we need to support staff, those staff that are feeling more vulnerable than others. And obviously theatre staff have worked in critical care over the last year. I myself met some of the theatre staff when we had the theatre reset week, which was 2 weeks ago. And there was, mixed feelings and mixed views about where people were. I think the overriding feeling was that the theatre staff want to get back into being theatre staff and working within theatres and getting our patients treated. I guess they're just tired. And, we all probably feel that sense of tiredness. So we just need to be mindful of that. And Bronwyn and I have talked about how we support theatre staff, some things we can do to keep that support in there. I also had a chat with John O'Hardwick, who Sam mentioned earlier as well, about some things we can do in there to support theatre staff. So I think it's going to be an ongoing thing, Denise, really, but I just want everyone to be mindful of it, that the people are tired, but they do want to get back to some kind of new normal, whatever that is.
Yeah, 100%. Thanks very much, Joe. Thank you.
Jill and then Karen.
Thank you, Chair. As Joe said earlier, we did have a really good discussion about this paper in Quality Governance Committee last week. But one of the things we were thinking about was how we look at patients that are now presenting at the front door at the beginning of the list, so to speak. So we may get some bounce back, which Simon referenced earlier. We may get people that have been sitting at home nursing something that arrive at the GP's door and need referring, so that may lead to an increase in numbers. But also the appropriate referrals. So again, Joe referenced earlier that 50% of the conveyances by ambulance to our trust are not needing treatment by us, which but by nature of that would tell us that there needs to be a huge amount of work around people presenting to us. So I guess it's a question again, Joe, but maybe even to Matt around our new Associate Director of Primary Care, whether there's those discussions happening across primary care about thresholds of referral and whether they're at an appropriate level or not.
Yeah, if I go first then, yes, there is, Jill. A really good example of that is we're looking at MRI referrals and the thresholds around that. And we're looking at different specialties because there are other ways to get advice and guidance for patients, advice and guidance being one of them. But it's clearly an untapped resource. There's Consultant Connect as well, which is a great way for GPs to speak to our consultants without referring people or referring them into A&E, for example, as well. So there is ways, but there's work to do, if I'm honest. And I will pick some of this up at the System Elective Care Board as part of our ongoing sustainability plan around RTT.
Clearly, when you change the whole nature of patients accessing the health service, GPs limiting personal appointments, more things happening by phone and so on, it's a complicated picture and patients take a little while to understand how they can access the health service now. And there's always been a slight temptation to go to where the lights are on, which is, of course, the emergency department and an acute hospital. So there will have to be an exercise in people understanding. And of course, GPs are not all reopening at the same rate. So there are some variations there for people to try and understand, and all of that ends up as 50% of ambulance conveyances don't require treatment by us, but they do require something. So it is an exercise, another little careful balancing act that I'm sure we'll come back to. Last two comments will be Karen and then Simon.
Thank you, Alan. Thank you, Joe. I just want to add my support, but I think you've picked up some of the points I was going to raise. Sorry.
Sorry.
Yep, but particularly I just wanted to say that I think there's a real opportunity through the System Elective Care Board to work with the independent sector, and I think that's what we need to really sort of focus on longer term in terms of our recovery and how we can work differently with the independent sector. And I know that as Polly Grimmett, the Director of Strategy now at Kettering, is the chair of the Elective Care Board, we can really sort of help drive that agenda as well. Thank you.
Thank you. And finally, Simon.
Thanks, Alan. Just a few points from a national perspective. So we've talked a little bit about the financial impact of some of the actions that we'll need to take. And many of you will be aware, it's been well trailed, that there's been £1 billion set aside to support elective recovery. And that is going to be part of the planning guidance that comes out, how that is accessed. And without going into too much detail here, what we can say is that's probably going to be accessible on an enhanced rate of activity compared to a threshold level. In other words, we'll all get a baseline level of activity. The more we do above that, the more we can access in terms of the elective recovery fund. Just to start thinking about that when we come back around to the discussions, as we doubtless will do in committees in April and May. The second, and it's a really good paper, and I wanted to say thank you for the paper because I thought it was a really good exposition of the issues. And it reminds me of the days when we were just starting out with RTT back in 2007-8. I can't stress enough that this is really important about the primacy of data. Understanding what's going on is going to be key. And the point that was made in the paper around validation is essential. We're all going to get challenged to make sure that our waiting lists are validated, because we know from national analysis that is done that there's a huge amount of duplicate entries, completed entries, other data quality issues that people have on their PTLs. So us getting ahead of that curve and really being confident that our data is good is going to be a no regrets move, and I think will be the new normal standard. On the point about bounce back, one of the things that nobody really knows, and if anybody tells you they've got the answer to this, then they probably are either in possession of some magic elixir, but you know, how much is going to bounce back, we don't need to know. We don't know. Nobody can tell at the moment. But our ability to keep track of our activity data and model forward what we think is happening locally is also going to be really key. We often report activity, but I think as we get into next year, we're really going to have to be paying attention to what the trends are in different types of activity. It was interesting to note, wasn't it? And I think Rachel made this point earlier on. There was a heavy dose of metrics there on how we're going to monitor our activity. And I wonder whether we need to be giving some thought about reporting alongside those metrics about how staff are feeling, alongside some of the metrics in terms of how we're doing in terms of reducing 52-week waits and the like. Maybe we need something alongside that as well. And finally, there will be a national productivity programme. It will be based on the GIRFT methodology. So I would be encouraging us to think as we develop our approach in this, what does GIRFT mean to us? Where are we at on it? And where do we think we've got opportunities as we start this really big climb back to normality? Where do we think we've got opportunities to do better and do better quickly? But a really good paper, a really good start to the debate, and hopefully some helpful observations on some context that will surround us.
Thank you very much, Simon. I think we might reasonably assume on the basis of all of the papers that have happened today that in the coming couple of months, as the planning guidance comes out, there will be a process through executives and committees that culminate in something at the May board, which lays out the recovery plan against the ask, against the financial resources, and allows the board to make an informed decision about what is achievable against our staff welfare concerns and striking a balance there. So I just lay that out as something that boards and committees and exec teams will have to think about getting themselves to, as I'm sure they will and are, by the time we come back to the May meeting to give a firm conclusion to what we want to strike as that balance. I don't see anything else. I did probably helped by the fact that I said that was your last comment, Simon. So, right, you're due a small break now. Can we be back at, where am I now? 10:56, 11:04, please, would be good. 11:04 back. Thank you very much. My computer says it's 11:04, so we should be back. Yep, good, excellent. We all there? Yes, we are. Okay, thank you very much. Okay, so it's a bit of the Chief People Officer show coming up in the strategy and culture session. So with a light relief from Andy Callow in the middle of it. So Mr. Smith, NGH annual staff survey results. Just as a point, you know, the CQC, our Care Quality Commission, the single biggest indicator they have for an organization is the staff survey results. So this is crucial stuff for us, and particularly in the conversation we were having about staff welfare, about what we're doing on staff well-being, about striking the balance between looking after our staff versus looking after our patients, which are not in opposition. They're the same question. This is a crucial bit of information. So, Mark, on you go, please.
Thank you very much, Chair. And you're totally right. So on Tuesday of this week, Tuesday was a big day this week, on the 23rd, across the system, we had Professor Michael West come to talk to us in terms of one of our Leadership Matters conversations, almost the godfather of the NHS staff survey. He helped put it together. And he said exactly as you've just articulated, and also one of the things in terms of why people look at the NHS staff survey results is that they are a very clear indicator of performance in every other area. So every other area of waiting list, finance, and so on and so forth, there's a clear correlation between improving staff survey results and improving areas of performance for every other area of the hospital within a 2 to 3 year period. So that was really important to hear him say that, and also to take on board his feedback and his comments in relation to a number of other matters. But in terms of our staff survey results in Northampton, I've fully disclosed the whole pack of every single graph you could ever possibly wish to have in relation to our staff survey results, and whilst they are available publicly on various websites, that I wanted to make sure that colleagues had a sight of everything there. But what I was planning to do was take us through a brief presentation of those results here this morning, and a quick overview and run through, if you like, as to where our staff survey results are, what our people said, and indeed what we're going to do about improvements in areas moving forward. So if I could take the next slide, please. Thank you, Kieran. So we have firstly, let's just point this out because this is a big celebratory moment, the best ever response rate that we have received in a staff survey in NGH. 50% of our colleagues took the time to tell us their thoughts, views and opinions upon us and indeed their work experience within our organisation. That's a 10% increase from 2019, which is fantastic. And when I take into account, having looked at this from a national and indeed a regional perspective, a number of staff survey response rates actually went down in this period for obvious reasons. People were working in different environments, people were highly under pressure, but our colleagues took the time to tell us exactly what they think about working here, and therefore if it wasn't already important enough, it's even more important that we make sure we take account of those thoughts, feelings and put them into some action and plans. There was significant improvement, statistically significant improvement in 6 out of the 10 themes within the staff survey. In terms of theme-related questions, 40 of them improved and 9 deteriorated. But it should be said, I think this is where it comes in with the but, that's the smallest word in English dictionary, one of the biggest meanings, is there's something there around the but. We are now sitting around the national average. So 2019, we know when I came here last year to give those results, we hadn't performed well in terms of a staff survey perspective. So we have performed better, and we should celebrate that most definitely from 2019 to 2020. But there is still work to do, and we are sitting in and or around the national average for a number of these statistics. In fact, if I could just share with colleagues my experience of when the staff survey results were published on the 11th of March, I had a phone call from our communications team to say, oh, we had some statements ready, but we need to release a statement to the Health Service Journal because NGH is in the top 10 most improved acute trusts in the country. I said, okay, good. And here we've got the statements ready. We can issue them. 10 minutes later, I had a phone call to say, we also need a statement because we were in the top 10 from a worst performance perspective in relation to our diversity, inclusion and discrimination statistics. So, it was that just demonstrated to me in that 1 20-minute period that we have done some great work and we have improved, but there is much more work for us to do too. So full results, as I said, are attached within the papers for everybody to see. If I could take the next slide, please, Kieran. And here is just that at a glance in terms of where we have improved since last year, but there, as I said, in terms of where we are against the national average. So there is still work to do, but I don't want to take away from the positivities and the positives that we have had in the last year. If I could take the next slide, please, Kieran. Thank you. So in terms of specific improvements and areas that we look at all of the areas of the staff survey, of course, but when we look in some of those improved areas, in line with what our people plan, indeed our group priority, and indeed our ambition and statistic is to be in the top 20% for staff engagement in the NHS staff survey results. So of course, that's one of the places we're going to look at in terms of benchmarking. Where are we now? Where are we against everybody? And how can we improve based on the feedback that we are receiving? One of those areas within the staff engagement themes is made up of 3 themes: motivation, contribution, and recommendation. And in terms of recommendation, you can see here in terms of our significantly improved areas, I'm going to struggle with that, as you can tell. Would I recommend my organisation as a place to work? And if a friend or relative needed treatment, I would be happy with the standard of care provided by this organisation. You can see the dramatic improvements in those, in the answers and responses to those questions between 2019 and 2020. And indeed, I'm able to deliver the care I aspire to. So those are things that we look at from a recommendation perspective within the staff engagement number of questions. There are, as I said, questions in relation to motivation and contribution, and we know we need to do some further work in relation to contribution in terms of how people can feel that their idea can be implemented and they can make a change in their work environment. There are, of course, some deteriorations that we are looking into. Unrealistic time pressures, relationships at work are strained, and during the last 12 months we have had more colleagues that have felt unwell as a result of work-related stress, which speaks to the point in relation to some of the health and wellbeing initiatives that we're putting in place. I should say also on that whilst it is great, it really is great for us to have services that people can access, it's even better if we can do something proactively about some of those stressors at the outset, as opposed to some of the stuff towards the end in terms of helping to manage that. And I think that's where, as Joe relayed in the conversation earlier, we really need to think about how, when we restart an elective work and the pressure that's applying stuff. As you heard, we are absolutely doing that. If I could take the next slide, please, Kieran. So in terms of national average, as I say, we don't just look at our performance against ourselves, we also very much look at the national position and where there are areas that we can improve upon. There are a number of questions, as you can see here, that are lower than national average, and you can see that they also centre in relation to colleagues experiencing bullying or harassment, and whether colleagues would feel secure in raising concerns. And in the last 3 months, people again have come to work despite not feeling well enough to perform their duties. These are obviously key areas that we need to explore and take action upon, and they are taken into account within the staff survey, within the people plan. We've taken into account the staff survey results from both NGH and KGH, so over 5,000 colleagues' views. In terms of questions that are better than the national average, we have, in terms of employer, we have made adequate adjustments to enable colleagues to carry out their work. Whilst you saw on the earlier slide, we have deteriorated slightly in this relationships at work are strained position. That is still better than the national average, but of course we want it to be as good as it was previously. And does your organisation take positive action on health and wellbeing? Well, I think testament to that is obviously a conversation that we had right at the outset of today's session. So I was going to move on to the last slide. I think that is the last slide for us. Thank you very much, Kieran. So in summary, there is still significant work that we need to undertake. The reason why I haven't gone into too much detail here in relation to some of the work that we're going to undertake in relation to equality, diversity, and inclusion is because we also have a later agenda item on that. And ultimately, the people plan that we're about to go into in a second contains the thoughts and feelings of all of the staff survey results of both Northampton and indeed Kettering, a numerous number of workshops that we've held with people to come up with what is it that we can do and we can offer to make the work experience of working within our organisations as best as it possibly can be. That's going to be ever so important. So I will stop there and take any questions at this stage before we move into the people plan.
Okay, they are a bit of a double act, but we will have the questions now. Where have I got? Denise and then Jill.
Yes, thanks. Mark, I just wanted to check a couple of things. Firstly, on one of the slides, you said that we've started feeding this back and releasing it to the staff. So what are the staff's thoughts on the results? What feedback have we had on the feedback, as it were? And also in terms of that top 20 place, and that this may have been there and I've missed it, but where are we at the moment?
Thank you, Denise. If I answer the last question first and then move on to the results, if that's okay. So we're in and around the national average. So we're not near the top 20%. We're in and around probably that gap, that 40 to 60% bit. We're right in the middle almost in terms of our results. We're middling in a number of those areas, and therefore that, you know, the ambition is to be even better, and specifically in relation to staff engagement, as I say, we need to be better across the board. But when you look at particular areas, if you're doing well and people are commenting favorably in terms of motivation, contribution and recommendation, then the data, because we now have almost 20 years worth of this data, demonstrates that the rest of the results will have improved too, because by virtue of what you're doing in the other areas, you've improved those bits, if that makes sense.
Yeah.
So that's really important. In terms of how colleagues have felt in relation to the survey results being distributed, we're in the process, we have done this in the staff briefings in the hospital, and we're in the process of working this through the divisional meetings, because there's even greater breakdown, if you can possibly believe that, given the number of pages you've seen that go into division specifics and department areas, and those conversations are being undertaken. Bronwyn and I have also discussed, and Bronwyn's had conversations with those who are in those groups or those areas that are in the top 10 and the bottom 10 in terms of results, and what is it we're going to do, and alerting people to that fact, because I think sometimes it can get lost in the detail of it, the enormity of it all. But having a bespoke conversation with the director of HR as to what is happening in your department, what are you doing to improve, and equally, as we continue to talk, and rightly so, learning the lessons about those in the top 10. What is it that they're doing that's different from those in the bottom 10, and what can we take from one to the other?
Yeah, okay, that's great. Thanks, Mark. I'll leave the rest of my observations or queries because I know what's coming in the people plan. So thank you.
Jill.
Thank you, Chair. Two questions, if I may. One is, we talked about this before COVID, which is doing more regular surveys of our own, like SurveyMonkey. And I think Simon referenced this when he was talking about data in relation to the recovery plan, and we could measure how staff were feeling as we progressed. So are there any plans to do something so that we don't just wait for the one big bang a year? And then the second question is probably more difficult. Are we able to know where the hotspots are in terms of bullying and harassment? Because there's obviously some culture issues there. And you can do surveys, which you will know, obviously, that focus just on culture. And then you can work with the staff from a bottom-up approach to look at how you can improve the culture in that particular area. It would be a massive sledgehammer to crack a nut to do the whole trust. But if you could focus on particular areas where there were issues, it's a really helpful way of trying to address them.
Thank you, Jill. So yes, we absolutely do know those areas. As I say, Bronwyn's made personal phone calls to those areas, and particularly it's the areas in those areas and those if you like bottom 10 or the 10 that need to have the most improvement, to look at it in a slightly more positive way, it's consistent. So it's not just bullying and harassment there, it's also discrimination, it's also a lack of time. So they're consistently low in all those areas. It's not a discrete place. So we are working with those 10 areas to see what we can do to make some improvements in relation to how we work with one another. I don't want to stray too much into the next item, but there will be a huge thing for us in terms of how we launch our values and make sure that they are lived and breathed within our organisation. We've debated them for a long time, we've agreed them. That will be an integral part of ensuring that people treat people with respect, integrity, courage. You know, it's a compassion. It's ever so important that we do that. So we are putting bespoke action plans in place with those areas to answer that question. But the culture survey idea is a really good one, and I will take that back. Do we conduct more bespoke culture surveys in those areas? From a pulse survey perspective, a more regular, frequent survey perspective, there are indeed pulse surveys. And Simon and I have been in touch with the national lead in relation to staff engagement for the national people plan, and pulse surveys are part of that, and they are, when we can talk to them, we will be getting some assisted help with some more regular, frequent pulse surveys. That is that you will see that in the people plan in terms of a metric that we want to keep an eye on and continue to report back via the people committee, and of course here, to make sure that it's, as you rightly say, Jill, it's not just a once every year. How are people feeling during September and November? It's a continuous thing. And then also what that enables us to do is, if we have put interventions in place or what we believe to be solutions and they're not working, we can change them, and we can change tack and do something slightly different.
Okay, thank you. I'm going to take the 4 contributions we've got up here, Mark, and if you want to answer them, fine, but if you want to roll it into the next item about the people plan, depending on what the comments are, just let's merge the 2 topics. So Bola and then Stuart, please.
Thank you, Chair. I'll make it quick. I think Jill touched on part of what I was going to say in terms of understanding what the staff would want, and how they would want to be treated. But I think also it occurs to me that there's something about empowering our staff, so that they know they can speak up about something. And in some ways, if that links into what you said, Mark, about the values campaign, because then they know that they can feel courageous, to speak about poor behavior. I think the other thing that occurs to me is about, we're doing a lot of things well, and certainly in the last year or so, and I just wondered whether we're doing enough in terms of communicating, the things that we have in, available for staff around health and well-being, the psychological support and things like that. So whether there's something there to look more into. Thank you.
Stuart.
Thanks, Chair. I think my comments are to maybe give Denise and Jill some assurance or reassurance, and to support Mark's comments. I've already had the phone call from Bronwyn. I've already had HR down supporting me, and we're already putting plans in place. And then on Bola's comments about we're doing enough, actually we knew some of these results were coming our way. We've had the OD team in supporting us. So yeah, for a bit of reassurance, that's all happening.
Thank you. Anne and then John.
Thank you. Just a quick one on the data. Are we triangulating the data with other surveys and other data that we have, for example, the GMC survey, HEAM survey, Freedom to Speak Up, just to really then get some further insights?
Okay, let's just hold that one. And finally, John.
Thank you, Alan. Mark, you highlighted the fact that there are some departments where there are several issues covered in the survey. That to me smacks of management issues, particularly middle management. And that's been a theme in the past as well. So what are we going to do about middle management training, which is an area we really must improve, I think.
Okay, so Mark, you can take them now or you can roll them into the people plan, because some of those questions are about going forward. It's up to you.
Yeah, some of them are. I would just address a couple of specific ones. So in terms of communicating what we do and ensuring that we tell people exactly what we do, coming back to Bola's point, we have now recruited 2 heads of communications, one for NGH and one for KGH, and tomorrow we're recruiting a director of communications, and we absolutely will be working upon that to ensure that people can see what is available for us, and also really importantly across our ICS. That's where I see this going from strength to strength in terms of what is our offering across the county, as opposed to specifically within the group, which is also great. And there are different levels from there too. From a data points or other data points and surveys perspective, and yes, and in terms of triangulating some of that data, that is where, as Stuart said, I've lost him on my screen now, he's down here. That's where we knew some of these things were coming from. So some of these results were not a shock to us. We know how some people feel in relation to their experience. I don't want to lead too much again into other areas, but we know from our international recruits, if you like, we have Toyosi, who is our clinical BAME fellow. We know that the experience of our recruits from overseas into the medical profession is not where we'd want it to be, and she's coming up with some fantastic plans about what we can do about that. So we know it's an issue, we're looking to address it, and we can triangulate it with the staff survey results, which also tell us it's an issue. The management, I will come on to that in the people plan, John, if that's okay. Again, I've lost you on my screen, but there is clear work that we're going to take forward in there.
Okay. Okay, everybody. Okay, Mark, take it forward into the people plan topic now, please.
Okay, just scrolling up through all of the stuff so on my iPad as quickly as I can. So in terms of the people plan, wow, this has been a journey. I know we like to use that word often in the health service, but the people plan that we saw in draft in January, not to rehearse that once again, but that obviously took into account the number of workshops we'd had and previous staff surveys. The 6 weeks post that event to now, this people plan, or the draft people plan that was, has been circulated, as we know, in a number of our committees. It has been circulated across both organisations, staff reference groups, some key stakeholders. We also have taken it into the ICS, so into our system people board for further comment. Colleagues here have given me comments, and quite often when you produce strategies or plans such as this, you ask for comments and you receive a few. I had over 10 pages of aerial point 10 feedback in terms of the original draft plans, which we then worked through judiciously in terms of making sure that we took those comments on board, because it's really important when people take you time to give you feedback. They want you to hear it, and we therefore need to respect that and listen to it. And hopefully that's what you see in the document that's before you today. There are a couple of key changes. Indeed, the very version that you have here has been slightly tweaked, given that we discussed this at the People Committee on Monday, the Joint People Committee across KGH and NGH, and it's been tweaked again slightly on the basis of some of the feedback we received around there. But just to give some headlines in terms of the plan as we see it at the moment. So the plan that you saw previously to the plan that you see now has 7 themes as opposed to 6 themes. It has a people partnering theme, and that people partnering theme was bringing on board some of the feedback that we had about, okay, so this is all well and good and nice from a corporate perspective, but how are you going to embed this or ingrain it within the divisions within both organisations? And our people partners will enable us to do that. How are we going to ensure that we continue to learn? We continually talk about learning, but we need to make sure that we're doing that from a people perspective too. How we treat one another is ever so important, and where we unfortunately do make mistakes on occasion, how do we take the learning from that and apply that to whether it be policy, process, approach, whatever that may be, and come at that from a slightly different perspective. And also avenues for people to speak up and out in terms of the people partnering domain. We also have made changes. So inclusion was also another huge piece of feedback that we received, and we have made sure that inclusion is encapsulated throughout the plan, but also, as you can see, centres within the theme or pledge of organisational development and inclusion. We felt that's really important. The organisational development element for us, it can almost be summarised in terms of how we do things here. So there's lots of what we will do, but how we will do things, how we interact with one another, how we work together within our discrete organisations, within ourselves as a group model, and indeed within the ICS and other stakeholders. That's really really important for us. I wasn't going to go into any more detail in relation to health and wellbeing. We know about that. We are enhancing our models in and around health and wellbeing. There are a couple of announcements to be made in and around health and wellbeing though, which I think is really important. So thankfully to Bola and Stuart and colleagues, we have been able to come up with a platform to devise the plan and to make it possible for us to continue with a free car parking provision for staff for 2021. That's going to be really important. This is the first time we're announcing that anywhere today, and we will more formally announce it within the organisations. But people have really seen a benefit of that in this last year, and we find that it's really important to continue to take on board those comments and take the appropriate action, which is what the plan hopes to do. As I said earlier, in relation to psychological support, not only are we working as part of the group, but with NHFT and NHCF in terms of the Stronger Support Together hub to give people fast access to mental health provision, which it historically could take anything up to 14 weeks and now will be in literally hours and days as opposed to weeks and weeks, which is going to be hugely beneficial for us. There's lots of physical health and wellbeing too that we need to look at. I could you'll have to stop me, Alan, because I can talk about this literally all day, and I would love to. That when we look at people planning, that's in relation to our international nurse recruitment, which I've referenced earlier too, and lots of different things in terms of our AHPs, our medical establishment, which I know Matt's already been taking a huge step forward on, and we need to embed that in, not just in NGH, but also again in KGH. Our volunteers, and taking the real good learning from NGH and the approach that we have here to volunteering into KGH, including the variety of volunteers we have, and indeed the variety of roles that our volunteers can undertake. We have to, and we have very much considered as part of this plan, that our corporate social responsibility and the situation that's going to occur economically in our county, and how we can help people to give something back in terms of volunteering, but also to help them to progress their career, which may be a different career to one that they may have previously envisaged. And we started to do some fantastic work on that. And of course, we know that this all has a real big impact on patient experience too. So that's going to be ever so important. I've talked around people partnering, around education. Already, and this has been so fantastic to see in the last few weeks, already our teams that work on our leadership development programs have already come up, if you like, of the best of both worlds between what we did historically or have done historically here in NGH, what we've done historically in KGH, and come up with a fantastic, I believe, pathway and prospectus across both organisations. That's just one tiny element around our education. Of course, we've got clinical and professional development that plays into that too. People processes is going to be a huge undertaking to ensure that we are aligned with best practice around people processes, but also with one another across the group. So this includes things such as our rostering, how we use our technology to its greater extent, so we can do away with the paper pay slips that we're all used to here in Northampton and move into that online situation. And we know from a rostering perspective, by having rosters in advance and having them more technologically advanced, that creates a better work-life balance for people in terms of knowing their certainty when they're going to be working and not. There's lots to do around temporary staffing, around rates of pay and so on and so forth. You've seen our agency position, which is not where it needs to be. It needs to be lower than it is currently. Lots of that will be can be worked upon by the new colleagues that we're bringing into the organisation, but there's also something we can do in relation to the processing and in terms of rates of pay of temporary staff, in terms of our temporary staff provision too. There is, I've mentioned already, OD and inclusion, which is going to be ever so important in ensuring that how we work together within our trust and again in collaboration is going to be so important. And you can see here that we've also commissioned a piece of work around an equality, diversity and inclusion strategy for both organisations, so we can take the actions that we need to. The metric I could look at, honestly, I know I can tell there's twitchiness, and I could talk. I will come to a stop in terms of the last paper talks about measurement and assurance, and we talked about this quite heavily at the People Committee too. Our April Development Committee will be looking at those metrics that we have suggested we will measure our performance on in relation to the People Plan, and therefore its success moving forward.
Okay, thank you. It's a great advert, for want of a better word, for the whole people directorate and the processes and all the stuff we've talked about balancing today. But it is, of course, the metric by which you will be judged. And that's what's in the last part of that. So coming through this is a plan with metrics and measurements, and that's going to be a large part of what I was talking about leading up to May meeting, but also well beyond that. So we'll go to Anne as chair of the People Committee, and then Jill, and then David.
Yeah, thank you, Chair. Thanks, Mark. A question really, I guess, for Simon, Eileen and the exec team. Key to driving improvements in terms of staff engagement and delivery of this plan will be the actions and behaviours of our leadership team, our divisional leaders and managers. And I just want to know how we're going to hold, or how you're going to hold them accountable for delivering on this, because the biggest impact on staff engagement, health and wellbeing is the line manager, and so it would be just interesting to hear what your thoughts are on how we can maybe move the needle on holding our leaders accountable. So that was my question. Thank you.
just hold that, and we'll gather the thoughts from Jill, David, and John. Jill.
Thank you, Chair. Mine was more of a comment. Another good discussion that we had at Quality Governance Committee last week was around a draft strategy for nursing, midwifery and AHPs. This is more of a professional strategy. We were very impressed that over 1,000 staff were engaged in developing the strategy. The action plan has yet to be finalised, but we did ask about its alignment with A, the people plan, and B, the digital strategy, because we also had the digital strategy on our agenda. And so we were assured that everything was aligned. So I think it was just worth mentioning that, but also to be careful we don't drown in strategies. If we're going to have an equality, diversity, inclusivity strategy as well, we need to make sure that absolutely everything is aligned.
Thank you. David and then John.
Yeah, thank you, Chair. I think this is something which you actually just alluded to, and it's concerning the measurement and assurance page. And, you know, there we do have a process whereby we are going to ensure that we are delivering what we said we're going to deliver. But just a point I make is let's make sure that we get the message down to our staff as well, exactly what we're doing as we progress in terms of implementation of this plan. I think it's absolutely vital that staff do know what we're doing.
John.
Thank you, Chairman. Yeah, I mean, it's a good plan. I'm very supportive of the plan overall, but I'm still looking for assurance as to what we're going to do to improve middle management and help their development.
Okay, Mark, assurance time.
Okay, no, that's fine, and apologies, John. Yeah, in my enthusiasm to talk about all the other areas of the plan, I lacked to talk about some of that work. So, in the People Committee on Monday, we had a really interesting discussion about this very point and around some human factors training, and how do we educate people in terms of how we could do things differently and how we interact as humans. So not necessarily all on task focus, but on people focus. That's going to be really important for us to be able to take forward. I think one of the elements that we will help to support our line managers and colleagues with is a change in policy. So quite often I see the extreme end, if you like, of where we get to a difficult case or a difficult situation with colleagues, and more often than I would like, we very much see how this it could have been diffused or dealt with at a very, very, very early stage in the conversation and the debate. But when you unpick that, when you look at it, we almost create this situation ourselves because our policy says you must do this and our policy says you must do that, our policy says this, and therefore people want to follow the policy because they don't want anything to come back to them and say, well, you didn't follow the policy. So there's something for us around how we change our policy and give people more confidence to have conversations. I mean, actually, Bola used the phrase fantastically in terms of courageous conversations. How can we encourage people to have those conversations at an earlier outset and know that it's okay to ask people if they're okay? It's not I don't really want to ask that. It could be a sensitive situation. It's okay to ask people, and it's also okay to be transparent as a leader and a manager sometimes to be able to say, okay, I'm not entirely sure how to deal with that, but let's work on it together, or I can go and find some more information. I think again, I've been a line manager for many years myself. I think there's this belief that we hold and we have to try and help and support and solve everybody's problems. So sometimes we won't be able to, and sometimes we have to acknowledge that. So there is quite a lot around human factors training that we've put into the plan, and Vicky O'Neill in our education team is taking some of that work forward. So that answers your point specifically that I forgot to mention earlier. In terms of, David, your point about staff and what are we doing, if I'm totally honest, one of the reasons that we've tried to keep the plan as concise as possible to 16 pages is that people will continue to read it. But I'm also mindful that people are very busy, as we've discussed today, and they might think, I don't really want to read that. Hence why on page 272 and which page is it now on our pack? On 278 of our packs, we have the people pledges on 278, which are just snippets of this is what we will do. So if you don't have time to read the hundreds of pages, well, not hundreds of the 16 pages, these are snippets, and how we communicate this plan, going back to my recruitment, as I talked about earlier, is going to be vital. It doesn't have to be a 16-page plan. It can be on small cards. It can be in a poster or so on and so forth. There will be lots of ways of communicating this. And the reason, and this was important feedback that we received from the last version on page 272, is what pledges and actions will we take? Because quite rightly, we have 10,000 very busy people that work across this group, and ultimately some of them will say to us sometimes, well, what is this, what's going to make a difference to me, what's going to happen for me? This is lovely words and usually management speak, but what's going to happen for me? And that was the purpose of that that page, if you like, was to try and give those headlines. This is what we're going to do. So you can see front and center was dedicated car parking. I wasn't releasing that it was going to be free until we had the conversation here today, and I'd signed it off with Bowler and Stewart because I'm wiser than not to do that without them. But there is something in relation to the access to psychological support, so on and so forth. These are the headlines. This is what you can expect to see from this plan, and hopefully they will not all take 3 years to be delivered. And as you can see, many of the deliverables center around 12 months as opposed to 3 years. Alan, and I'm also very mindful of the fact that this is what you will, and Simon will be holding me to, and the board will be holding me to account for in terms of delivery. However, I acknowledge quite rightly Anne's point that Simon, Eileen, and my rest of my colleagues have got a part to play in this, and I'm sure they're going to come in a second. Whilst I have a breath.
Nothing like spreading the responsibility at the right point. Yes, it is. Of course it is. It's a whole board responsibility. So finally, Joe, then Aileen, then Simon. Joe.
I think Simon was first. Am I okay to go ahead of you, Simon?
Yeah, but I'm putting him last.
Okay, right. So yeah, just a couple of points. Obviously, as a leader in the organisation, it's up to me to hold everyone to account as well, but to work to the values of our organisation as well. When I met with Bronwyn, I agreed my top 3 priorities. One was how we support our theatre staff, our ward staff and our outpatient staff to recover. So that's clearly one of my top priorities, and I work with Mark and Bronwyn on that. Second to that is how I develop the divisional teams so they can hold their teams to account and they've got the skills to do that. And third is equality, diversity and inclusion. I've put myself forward as one of the leads to work with Bronwyn on that. And then my other point is around, we have divisional assurance days, which are like divisional performance meetings, and I want to revamp that with Eileen and the rest of the exec team so that we do hold the divisional teams to account, but they're really clear about what our expectations are and what their objectives are, and that we give them the support that they need as well to carry out, you know, holding the teams to account in the organisation and to help them unblock stuff. But we also need to give them the freedom to run their divisions, and we support them to do that. So there's lots to do in that space. Thank you.
Okay, thank you. Aileen.
Thank you. Not going to repeat what everybody has already said, but I think, you know, certainly for myself and as a part of the executive team, you know, we have to lead by example with this. And the real acid test to that will be when we become, you know, we're under pressure or things don't go quite right. How do we communicate with our line managers who then communicate with their teams? I think we do have to set the expectations. We know where some of the problem areas are, but not wishing to single those line managers out straight away. Where we know there are problems, as Bowler has already said, it is about honest and courageous conversations and what is that impact that behaviour has on teams. And then, you know, most importantly, as long as we are making sure that we are supporting and giving our line manager colleagues the tools and techniques to be able to manage their teams well, if that doesn't then turn out to be the case and there are still problems, we do have to deal with that, as opposed to, you know, it festers and it goes on for long periods of time, because we will see that back tenfold if we're not careful. So, but we have to lead by example, particularly when things don't go quite right. Thank you.
And finally, Simon.
Thanks. First thing I'd like to say, I suppose, is well done to Mark and the team, because this is a huge piece of work to get to the place that we are today, and it's important that we acknowledge all of the effort that's gone in. And I think it's testament to the chord that it's struck with our staff groups, the amount of feedback Mark's received. I've never personally heard him refer to font size before today, so that tells you something about how dense the feedback must have been, I suppose. It was a great question, Anne, I thought, and my response is yes, of course, but how do we change that you to we? Because I don't think it's about how just the exec deliver this. I think it's about how we do this together. And one thing I'd like people to think about, I suppose, as a consequence of this, everybody here is what can I do to support implementation of the people plan? Because everybody around this virtual table today can make a contribution. I really liked what Jo had to say, for example, about some of the ideas that she's got. And I think we've all got a contribution to make. So I'd invite everybody to think about that, and maybe when we come back and talk about it again, that's something we could all commit to sharing, what our personal contribution is going to be. Mine, just to be clear, is that I've committed that we will bring the two exec teams together. And when I had my appraisal with Alan recently, I was saying, other than obviously all of the group priorities for the year ahead, one of my objectives for the year ahead was to make the teams, the exec teams, a place where people felt it was a really great place to work. Notice I'm not there talking about deliver a bunch more stuff. I'm actually talking about people find it an inspiring place to be and really want to come to work, because my belief is that if you do that well, then that bleeds into the pores of the organisation and actually helps people feel differently and better. And it starts to touch those middle managers that we were talking about. I wanted to make one more practical point, which I think came up in the course of the conversation. And Mark's already alluded to it, as have some other non-executive colleagues. And it's this, we already know that when we look at the staff survey, it's an aggregate sum. And today we have looked at it in aggregate sum. And that's inevitably the way we have to look at it. But as Mark and others have said, there is a huge amount of detail. And we know when we look at that detail, the people who don't feel as good about working here. And I think the other commitment that we need to make, all of us, is to be willing to go and meet those people in their world and have those conversations, which may be painful for us to listen to, and actually understand why they feel the way that they do. Because I think great though this plan is, and I do think it's a really great piece of work, we've also got to go and understand the needs of those individual communities within our organisation and respond much more specifically to those. Final thought, I think we need to commit as a board to investing time in debating it, just as we've done today, because if we are as serious, we need to be as serious about this and valuing it with the time and the measurement and all the things that people have said as we're going to be about elective recovery. That was everything from me, thanks.
Okay, all good stuff. And clearly the comment about, it's a whole board responsibility to strike that to address these issues is pretty pivotal. So we will be coming back as part of the stuff I laid out as we move through the next couple of months, but also repeatedly, it's a short-term, medium and a long-term plan. So thank you, Mark. Thank you, the team that put it together. Thank you all the staff that contributed to it. It's really good stuff. Well done, everybody. It did take a while. It took a long, the gestation was a bit long, but it did get there and it is impressive. Okay, group digital strategy, Mr. Callow.
Thanks very much. So colleagues, you will have seen this strategy through the board committees. I think Mark and I went through the committees like the worst kind of double act, talking this through with you. But I'm really delighted today to put this before you for approval. So this is the final version of the group digital strategy. And similar to Mark's story, what you see before you is accumulation of lots of engagement, feedback and energy from people across our trust and from the public. So before I sort of give you a bit of a summary of the strategy, I just want to talk about some of the things we've done in the digital realm that we can be proud of in NGH in the last year. So we've enabled many people to work from home, which has really helped in our COVID response. We've enabled video consultations and extended virtual consultations in general. Towards the end of last year, NGH was awarded the Robotic Process Automation Centre of Excellence status. Get your teeth around that. And we're currently supporting another 10 trusts across the country to explore this technology. So a real feather in our cap. We've done all the basics. We've kept the show on the road. We've continued to maintain cyber security and all that good stuff. And we've made the small start towards establishing an electronic patient record program. So that's brilliant, and it's worth taking a moment to celebrate. But let's be honest, despite all this, by external measures, we're still classed as digitally immature, and we've a long way to go. So what you have before you is an ambitious strategy to get us there. And I've said on many times in the committees, this is our moonshot. This is our set of audacious goals. And put simply, actually, we don't know how we're going to get to the end point on many of these things, but I am confident of progress. And as well as the targets that are set out in the themes, and you'll notice there's lots of measures in there, we'll hold ourselves accountable to external measures and use the HIMSS assessment as a benchmark, and we'll aim for the top level. And I'm not aware of any organisation that's made that many HIMSS steps in 3 years. So, you know, when I say moonshot, I really mean it. And there's also an emerging What Good Likes maturity standard that I've been part of developing with NHSX colleagues. And my aim is that we're ranked #1 on this. So in essence, I want our group to be in a position where we are the go-to group to understand how to do digital transformation, to deliver excellence for our patients and staff. And being the most digital hospital group in England will put the hospitals on the map and will gain accolades through the NHS, because when we say we do something, it happens. Our clinicians rave about the software and the kit they have. Patients give us excellent feedback, and our teams recommend our trust to be a great place of work. So how will they make that happen? So firstly, in the strategy, you'll see a core set of principles that we will work to. And they're, you know, the core one of those that I'll just focus on is about focusing on user needs. If we really understand what patients, staff and clinicians need and put them at the heart of what we do, then we can't go far wrong. So over these past few months, and similar to the people plan, this has been an accelerated program. The themes you see have been adapted along the way, resulted in 8 themes being selected. And I won't go through the themes, but I'll flip it around in another way to say, why is this important? So the first one is about improving the patient experience. Many patients have told us they've welcomed not battling with our car parks during the pandemic and have felt assured through telephone conversations. But there's lots more we can do in this space. And we want to give them access to their record, increase remote monitoring and control over appointment bookings. And that's set out in theme 1. And we've mentioned it actually today, haven't we? Happy staff give great care. And so my ambition is this strategy is to give people the tools that they go beyond just coping with, but to loving, because it helps them to do their job. And that's picked up in theme 2 around how we support our staff, and theme 3, which is about doing the basics brilliantly. The next thing I want to mention really is about the visibility of the full patient records. Our clinicians often are quite blind to the full picture of what's going on in a patient's journey. And we need to recognise that our care journey crosses many settings, of which NGH and KGH are just one. So moving to a group electronic patient record will help address this, and that's set out in theme 4, and in theme 6 goes into the way that we work with our partners. And again, we've talked about it today around how we improve data, use data to improve care. And as we grow our electronic record, our capability to review outcomes and assess performance will increase. And you'll see that set out in theme 5. And then finally, giving back time to care. We have 220 clinical systems across the group. Many of them overlap in functionality and very few of them join up. And each one has an overhead. So moving to consolidate these systems will really help have a consistent experience across the group. And that's set out in theme 7. So colleagues, I hope you're able to approve this strategy and help us take the next steps towards our digital future.
Okay, this has been through, again, like all things that come to the board at this point, it's been through all sorts of processes to get ourselves here. I think it's a remarkably ambitious strategy. We did have a very, very good meeting with NHSX, which is sort of NHS, well, it's not NHS Digital, but it sort of is, in terms of our thinking about how to take this all forward. Now, we'll talk about that more in the afternoon meeting, but you know, that too was a representation of the kind of quality of work that you've done, Andy, you and your team have done, because it does require a team, but it's also about how we are beginning to be seen by the rest of the system. And we're not, or the rest of the country and the national bodies that look after this. We're not an organisation that only does things if people throw us a load of money for digital. it is part of our DNA that this is going to be the solution to the process. So I'll take Anne and then Rachel and then Mark.
Thank you, Chair. We discussed the digital strategy at the recent People Committee, and everybody was really, energised by it. But one of the questions that came up from medical education was the fact that we've got some fantastic technology, virtual reality technology, that's really transformational in terms of educating our medical students, but we're really hampered by the lack of infrastructure in terms of Wi-Fi and 5G. And I know we had the opportunity to partner with Vodafone that could address it, but I wondered what we're doing about addressing the infrastructure, because that could open up so many opportunities to drive innovation, to partner with third parties. So I just wondered, Andy, what your thoughts were on that, because the technology we have is pretty amazing, but we're not able to make the most of it.
We'll hold that, Andy, and gather some other thoughts. Rachel, and then Mark.
Hi, Andy. In your opening, you talk about, and you've mentioned it quite a few times, our ambition is to be the most digital hospital group in England by July 2023. Is there something in your mind that when we get there, you're going to say, yes, we've achieved it, or maybe hopefully not, but what is the one thing that you're going to sit back and go, yeah, we're there now? And my second question is almost the flip side to that. What is the outcome you are most concerned about achieving, and what can we do to help?
And Mark.
Thank you. Rachel, that's pretty much word for word. The second part of your question was my question, which was, apart from being insulted by being called the worst type of double act by Andy, my question was, in terms of the implementation of the strategy, what's the biggest concern? And exactly that, what can we do to support it?
Okay, Andy, off you go.
Yeah, so I think the comments around some of the foundational work are absolutely valid, and that's picked up in theme 3, which is around doing the foundations to build on. And you're absolutely right, we can't do all this great stuff if we haven't got just the basics, like a universal coverage of network. So you'll see some targets in there around network availability, world-class Wi-Fi across the site. So certainly that's built in there, and you'll see targets in year 1 and year 3 about putting that in place. So hopefully that's gives the board assurance that that's definitely taken into account while we're doing all this other good stuff. Rachel, in terms of the sort of most digital hospital in England aspect, so we're going to do this at the external measures, and that's all going to be great for external validation. But the thing I think is most important will be around net promoter scores from clinicians. Do they, I mentioned it before, lots of clinicians say they kind of tolerate or they battle with the software and the tools that they use. If we have people who actually find that the things that they work with actually help them to do their job, and that we record that through net promoter scores, then that for me actually will be more important than achieving the HIMSS, because that will really make a difference on the ground. In terms of what I'm worried about, so I guess moving to our group electronic patient record is going to be a challenge. So on Thursday, Matt Hancock announced that NGH was in receipt of seed funding to put our business case and proposal together. So that's the first start, but we need to access the funding in order to do that, and that's the piece of work that's happening at the minute. So the thing that's occupying me at the moment is making sure that that's breaches that affordability gap, and we move towards that. And there's probably some conversations that we as a board will need to have in terms of priorities and where we'll see the benefits. In longer term, there's lots of big targets in the strategy, but weirdly, the one that sort of gives the team the most wobbles is around moving to a single log-on. Now staff tell us the pain of having lots of different logons. If you imagine across our group, we have 220 clinical systems and over 100 corporate systems. So working our way to go for this aim of a single log-on, it feels like this. Well, how we know we can get there. We know there's technology that allows us to get there, but how will we get there in 3 years is the kind of thing that has everyone scratching their head at the minute.
Okay, I'm not sure you clearly thought about what could the board do that would promote the likelihood of this coming to pass, apart from going, yes, Andy, it's all terrific.
Well, so I think we've started to become, as two boards, more aware that actually this isn't something that everyone goes, right, this is the technology thing is over to you, Andy. This is around all of us appreciating that there is no business without some independent technology in it, and so we all need to be tech curious. If you remember the conversation we had as a board, two boards last year around that, being aware of what's going on, and I gave you a list of really difficult questions to ask me at various times, and I invite you to go back to that list and look at that. So so that's a kind of a broad term. There is going to be some wrinkles along the way. So I think the thing I would ask the board is, as we move to our group electronic patient record, this is a hard piece of work, and we need to hold our nerve during this time, because sometimes it will feel like it gets worse before it gets better towards that goal. And so your support in helping us go along that way would be really appreciated.
Thank you very much. I think that is a pretty clear exposition of what the problem is, if you like, of doing this. Right, thank you very much, Andy. You can take it your strategy is approved. It is a seriously good bit of work, and the ambition is pretty impressive. And I think mostly we have begun to put together the equipment, money, people to deliver it. We're not there yet, obviously. It's a big thing, but there's a lot going on, and there's no doubt that the teams are energized by it, and they have not always been energized in the past in either trust. So thank you very much. Okay, item 14, Mark, back to you again for the Smith Show, equality, EDI, BAME, staff support.
Thank you, Alan, and thank you, Kieran, for sharing the presentation again. So this was, we had, if colleagues recall, we had Liana and Tim come along with myself a couple of months back to present some plans in relation to what we were trying to do or trying to put in place in terms of improvements in our diversity and inclusion across the organisation, specifically for our colleagues from a BAME background. And this report is just to provide an update to that, to the board as it stands at the moment. So I won't take a huge amount of time, but it is important that we take a look at this particular topic. So if I could take the next slide, please, Kieran. You have seen this was in the staff survey presentation earlier. This is our biggest gap from a national average position, and therefore indeed also from a top employer position across the NHS in terms of our staff's feelings about how close we are with equality, diversity and inclusion, and that's really important. I'll come on to some more of that in a second. If you could take the next slide, please, Kieran. As you can see here in the right-hand side, this is a growth for us. This is a growth area, and one of the ones that we definitely don't want to have. So in the last 12 months, have colleagues personally experienced discrimination at work from manager, team leader or other colleague, which obviously stands to John's point in relation to the people plan. You can see that this has been an area where we have, it is growing as opposed to deteriorating. And just as we know with the staff survey, you want to be green, not orange. And unfortunately for us, we are getting closer to that orange position. So we really need to increase people's understanding and awareness and to take positive action in relation to this particular area. The next slide, please, Kieran, demonstrates that we do, again, breaking this down, just going back to the earlier point, we do break all of the staff survey results down. We do look at areas and hotspots, and what this demonstrates in terms of our organisation at the moment in looking at hotspot areas, there's clearly many, with the exception of women's and children's who are above the national average. But whilst we have seen improvements internally from 2019 to 2020 in many of our areas, these are still significantly away from from our diversity and inclusion and national average position that we don't aspire to be. We aspire to be even better than that, but let's take one step at a time in relation to this. And if I could take the next slide, please, Kieran. So you can see here, 2020 to 2019 to 2020, we're making improvements. So I suppose in terms of a summary, we're making improvements, but not when we compare ourselves to the national average. And of course, as I say, we have an ambition to be even better than that. So we are making and seeing some improvements in this particular area, and the statistics bore that out. So we had the full workforce race equality standards given to us. I think Tim presented it back in July to us, but we still have some way to go from a national perspective. And I'm going to come on to a little bit more in terms of those actions in a second. If I could take the next slide, Kieran. You can see here, as articulated in that graph, the discrimination element by a manager stroke colleague to colleagues from a BAME background is increasing or deteriorating further, and we need to do something quite quickly about that. If I could move on to the next slide. But one of the great things that we have here in our organisation is our network, which is a fantastic network led by Liana, as you can see here in the left-hand side of this particular picture. And this network is absolutely growing and is undertaking a number of actions that they came to discuss with us a couple of months back. I have to say that they're growing great guns, including the aspirational leaders element of the network newsletter that you can see here on the right-hand side. That was not the most straightforward interview I've ever undertaken in terms of when they come to ask me lots of difficult questions about my journey and how I've got to where I've got to. And it's ever so important for us to look at that from all colleagues, from all backgrounds, in terms of how people how people have arrived in where they are, particularly today. The group and the team are working fantastically in relation to amendments to our recruitment policies. In terms of visibility in the organisation, you can see here we really have some strong support from our network, and we need to put even further support behind it. And one of the areas that we have achieved that in is that Andy will now take the executive lead on this network, as he has that role in KGH as well, because then we can cross-pollinate the ideas and the suggestions between one network and another. There is very specific items that we need to undertake, particularly in supporting our network, with regards to time. So time to be part of the network, time to administer the network, and time to take forward actions from within the network. We've undertaken a piece of work in relation to that in KGH, and we're just about to do that here in Northampton too. It's really important that we create time for people to do this, because we have had lots of goodwill, grace and favour that people have put into the establishment of the network, and we really need to now demonstrate our commitment to the network. If I could take the next slide, Kieran, please. I'm not going to go through these slides because the group and the network are currently debating this. They asked me just to include these slides as a demonstration of the types of things that they're debating in their area. And ultimately, the group and the network are the people that will make these decisions, these informed decisions, and then ratify them or bring them to us for ratification, because this is the very nature and the purpose of having the group to debate these things, such as whether or not to rebrand the BAME staff network as a group. If we can go through the next couple of slides, Kieran, at the pace. I'm not going to talk to each one of them. Obviously, it centers in relation to our strategic priorities, of which is people, and we talked about the people plan. The group have given a bit of context about how it was established and how it's come to where it is at the moment. And then the next couple of slides go through some suggested naming conventions for the group. And do we move away from BAME as a terminology or not? And as I say, the group here have gone through quite a lot of in-depth thinking as to what they therefore could be called, and the rationale behind some of that here. And you can see strengths, weaknesses of each are being debated, and that continues to be debated in our network, which is why this is not here for us to make a decision on this. This is just a showcase of some of the work the group are taking forward, and it's so very important to us. If I could take the next slide, please, Kieran. So this is some of the progress on update of actions that we previously brought to the board and things that we said we would do, and where are we against those elements. So in terms of colleagues from within the BAME network advising on recruitment panels, we do have that in situ. We have had that in certainly in a number of our senior appointments, both again in NGH and also in KGH, and we will continue to do so. That's providing a huge opportunity for colleagues to have a review as to what we do, but also to inform our decision making and also educate us in relation to unconscious bias. There is some policy changes to make sure that this is consistent. And fortunately, a really proactive member of the network works within my team in the recruitment team. And so Andre's working on that as we speak, in terms of making sure that we've got the correct policy process and application in terms of making sure we make the most and we get the most learning from having colleagues from a BAME background on those selection panels, and indeed looking to extend it against those from all protected characteristics on those particular panels advising us. I've talked about the role models within the group, and they are increasing the exposure of the network. I mentioned earlier in terms of the work that Toyos has been undertaking with our international doctors, and I'm sure Matt will be receiving a paper soon as to what we can do differently around that, and then that will be a discussion with myself and Matt, and then indeed other colleagues from within the executive team as to what we do taking that forward, and how do we make it similar to that experience that our international nursing colleagues receive. The network are fantastic in terms of provision of support in place for colleagues who are victims of discrimination, and signposting in terms of what we can do and providing that support and advice. Our workforce race equality standards data, we said we would share at divisional level, and we have, and we will continue to do. Pretty much similar. I gave a high level in terms of the divisional perspective, but there's equally metrics underneath that we will ask our divisional colleagues to look at, like we do all other metrics. We have the reverse mentoring established, so some colleagues in and around the screen, as I can see you now, have been contacted and have started developing those relationships with your co-mentee mentors, and that's around really enriching our experience and exposure to people's experiences in the organisation, and vice versa in terms of support and time and we can give to those colleagues that are supporting us to learn about their background. We can equally give them support too. And the focus on diversity and inclusion in our board meetings is exactly this, is it not? And this will continue. Not to mention, obviously, our staff survey results, which demonstrate that it absolutely needs to maintain and be a priority for us as a board to consider and continue to look at. This is totally not an area where we are succeeding. Yes, we've seen some improvements from 19 to 20, but we've got a lot more work to do, as I've already articulated. So, what is that said work? I've already talked about the equality, diversity, and inclusion strategy. And Jill, you're right. It's not. I'm not trying to create strategy-itis here, where we have strategy after strategy after strategy. But I really want to pay specific attention to the actions that we can take from an equality, diversity, and inclusion perspective, and cross-pollinate that learning between both organisations to make sure we take the best of both and forward with the people plan. The network name is being reviewed, and again, the great work around the colleagues in NGH have shared that with KGH, and that continues to be debated and discussed. One of the things that we would like to take forward is the expansion of our network sponsorship to include non-executive directors, and I'm not suggesting we have a hands up process here now, but people who would wish to be in contact with the network, if they could come to myself or Liana or Bronwyn, we can absolutely get you into that network and to be part of that particular team, making an influence in decisions about how we approach this topic in the organisation. And there's development of the aspirant BAME Nursing Midwifery Leaders Programme. There's a slide on that following this, which is something that we are working across the county of Northamptonshire. If I could take the next slide here, Kieran, across the county of Northamptonshire in supporting aspirant colleagues from a BAME background. This is, we have a number of things that we look at, as you know, from our workforce race equality standards data, and that indicate how diverse we are in our thinking and indeed appointments within the organisation. And one of the barriers it appears to that at the moment is to encourage our colleagues from a BAME background to come onto these leadership development programs, to enable them and equip them to come forward in those selection processes in the future to senior roles within our organisation. And this is just an example of that, again, working across the ICS and indeed the county with our regulators from NHS England and Improvement. If I could take the next slide, please, Kieran. So this is the slide that we finished on in our last conversation on this particular item. And again, we will continue to just keep refreshing our mind on it in terms of how we will continue to monitor our progress. Do we have an appetite? Can we ask, etc.? And what we aim to see, that has not changed because we have not got there yet. So our res position needs to be improved in terms of career progression, and you can see some of the actions we're putting in place. The bullying, harassment, and indeed the discrimination scores and the feedback that we receive needs to change. As I say, we're in the growth in the domain of discrimination, and we absolutely need to be reversing that very quickly. We did talk at the last board meeting, and I've still included that here in terms of the rise and fall. The more dedication and exposure you give to this topic, you can sometimes see an increase in some areas before this drops off. But as I say, also importantly is for us to take the comments and feedback that we receive from the reverse mentoring program. I do not yet have my reverse mentee mentor in NGH. I certainly have one in KGH, and the relationship that we have struck up has already given me huge insights into what happens within an organization, maybe unconsciously, maybe not, in terms of how certain people are asked to do certain things at certain times, and how we can then use our positions to support and influence the change to ensure that doesn't happen in the future. I will stop there. I will pause there, Chair, and take any questions.
Still off. Paula, then Sharon, then Andy, please.
Thank you, Chair. I just wanted to lend my support, to all the work that has been done so far. Certainly in the last 2 years or so, the Trust, I think, has made a lot of progress, in terms of this area. I mean, as Mark said, obviously there's a lot more to do, but I think we should pause to celebrate, the progress that we have made. And also, especially for me, I found the reverse mentoring, and I think a few of us on this call have been involved. I found it really useful to understand what it is like to be in the other person's shoes and the experiences, and hopefully be able to bring some of that back, to the board to say, how can we do things even better? Thank you.
Thank you. Sharon.
Thanks, Mark. A subject I absolutely feel passionate about. Just a little plug, though, to mention the shared decision-making councils, international councils, voice of 300-400 international nurses. I think we probably need to do a bit more work to try and get them much more integrated into the network, because there's some really good work doing. And finally, just an observation on the developing the aspirant BAME nursing and midwifery leaders programme. As chair of the Northamptonshire Council, I have the privilege of looking at the volume of applications that we've got coming through. And one of the things we've learned out of that is quite clearly we have to encourage nurses to apply for it. It's not something culturally that they always find easy to do. But of the applications that we're going to be considering in 2 weeks' time, so far 60% of those come from NGH, which I think it tells us something around the need for some leadership development for this particular cohort of staff.
Crikey, I have a lot of hands up. You can forget the break between this and the private meeting at the rate we're going here. Andy.
Yeah, just briefly, Alan, just really welcome this. And I think the thing where this and what's set out in the people plan just indicates the organisation's willingness to not just be around the issue of the moment, but to really embed it in our organisations to make sure inclusion is what we do. And the second thing I'd just say is around the reverse mentoring. In actually, as to echo what people say, it's just a fantastic way of opening your eyes, and certainly my mentor is not shy at holding me to account.
Yeah, nor is mine. Where am I? Anne, then Matt, then Simon, please. Oh, sorry, can I pause that? Sorry, Denise had her hand up first. Denise, then Anne, then Matt, then Simon.
Okay, thanks, Alan. Yeah, I mean, a couple of points. Firstly, like Sharon, I do feel really strongly about this. It's great to see the stuff that's been done, but in truth, it's not got us to where we need to be. So I think our focus has to be moving forward on what are we going to do differently to really get us to where we need to be here. And I think that as a board, we really need to think very carefully about what our role in that is. We incorporated through People Committee into the People Strategy this phrase of zero tolerance around bullying and harassment. And what does zero tolerance look like at NGH? And I think we've all got a big role to play in that. My question for Mark is around the strategy, the draft strategy, and whether that strategy, Mark, is going to be based on any sort of independent research and expertise to make sure that everyone's really enthusiastic, but we just need to make sure that we are targeting things in the right way here.
Thanks, Anne.
Yeah, thank you. I wondered, Mark, how we're using the network to get more insights into best practice. For example, the Royal Berkshire are like in the top 10. I think they're number 1 in terms of their progress on EDI. And I wondered if we can use members of the network to go out to, Royal Berkshire, find out, what they're doing that's different to us, and maybe bring that back to the board, get more board visibility around this, just to reinforce the fact that we take this, very, very seriously, and we're supportive of any ideas to make progress.
Mark, do you want to respond to those 2 points?
Yes, absolutely. Yeah, thank you. I'll perhaps in reverse order. So, and you're totally right. The issue that I just have ever so slightly, which I slightly alluded to, is that we just need to make sure we give protected time to colleagues within the network to undertake this. What I don't want to do, and we've talked a lot about pressure on colleagues today, is to put too much upon people in their own time and sort of, as I say, the grace and favour approach. So we just need to allocate, I feel, before I give them any more tasks, we need to just allocate a bit. And we're not talking hundreds of thousands or even thousands of pounds. This is not, this is not huge, big money that we're talking about here. We just need to be able to allocate time for people to do exactly that, which is to go out and find where the best practice is currently and how do we bring that back and take a look at incorporating it into Northampton. Which then brings me onto your point, Denise, too, in relation to the independence of the strategy review that we've had it's been conducted by an independent person. So we haven't had somebody from within either organisation undertaking it for many reasons, but I felt it was really important to commission that independently. And they have, of course, met with the teams, met with the network leads and certain many other colleagues, but it is an independent strategy that I will be in receipt of, I'm told, in a week's time.
Matt.
Thank you, Chair. So just a relatively minor point in relation to the Developing Aspirant BAME Nursing and Midwifery Leaders programme. I think it's an excellent concept. When I saw it presented, I thought that band 6 to 8A might be starting too high, because when I've been taken to some focus groups by TOSI, predominantly of international medical graduates, but sometimes some international nursing graduates have joined, and quite a common theme from both groups is a sense of frustration of not really knowing how it works and how to get onto a ladder of leadership. And I wonder whether we could consider broadening the eligibility to include our band 5 nurses for that. I'm really welcoming the news that Andy is now sitting across the group leading on inclusion, because there will be an awful lot of cross-pollination, a lot of good ideas that I'd love to learn from Kettering. TOSI, who, as Mark has already said, is developing a sort of a programme for supporting international medical graduates better, particularly new arrivals to the NHS, which we're going to take, I think, to the joint people development session next month, and started taking me on ward rounds around the site, out and about together to hear experiences of colleagues, and it's quite a powerful tool. And it's those kind of just little things that, if we cross-fertilise, I'm sure will add value to our understanding and therefore opportunities to improve. Thank you.
Thank you. I'm kind of assuming your hand is a legacy hand, Sharon. So final comment, Simon.
Thanks, Alan. So the first thing I want to say is welcome the plan. I've missed a chance actually to congratulate Sharon on the work around the international nurses earlier on. So I'm going to take that opportunity here to say that out loud, because it's a pretty amazing achievement actually when you think about some of the nursing vacancy rates that are up and down the country, and indeed on some of the international nurse recruitment programs where vacancy rates have not been in the place that they are here. And I wonder whether one opportunity we could take, linking some of the discussions that we've had today, is what aspiration would we set ourselves if we were sitting down here in a year's time about that vacancy rate, and how can we support that happening? Because that's something to be really treasured, and it clearly links, I think, in my head to some of the conversations we've just been having now. A couple of other thoughts, and I'm painting these not as kind of absolutes, but more tonal suggestions, I suppose. So I wonder, we spend a lot of time here, don't we, rightly talking about patient stories, but I wonder whether we ought to have diversity and inclusion stories here each month. and actually invest in hearing from different groups across our organisation and just listening to the stories. I had the privilege of meeting somebody who's going to be helping us out in Director of Comms interviews tomorrow, who is actually from Poland and was talking about her experiences post-Brexit to me. And it reminded me of the fact that there are lots of inclusion issues that are in our day-to-day life that are really, really important to those people. And giving them thought and time and consideration here, I think would be a really important step that we could take. And final thought, tonally, as I said, maybe no conversation about me without me. So perhaps we should say every time we talk about this, we actually make sure that our diversity inclusion chairs, people like Liana, but others, are actually sitting in the room with us, rather than us talking about things we're going to do for them or help them. They need to be part of our conversation around this table.
Okay, thank you very much. I think that's all helpful. We might wish to develop the concept of negative vacancy rates. That would be an interesting question for how we do things. And we might well want to think about the whole diversity agenda amongst the board itself as we move forward, which we will be doing, of course. So thank you for that. This is not a short haul, this is a long haul flight, and this is going to take a fair bit of time to get right. But I think the 7 A's are extremely helpful in that regard. So again, good piece of work, well done. Thank you very much for all your efforts, and thank the network for all their efforts. Right, governance, terms of reference for ratification. You have Group Finance and Performance Committee terms, Quality Governance Committee for NGH, Finance Performance Committee for NGH, and Hospital Management Team for NGH. They've all been through process, either through the CPC for the group work or for or through their own committees. And Claire has obviously seen that process. Are we happy to endorse those? Any problems? No, no problems. Thank you very much. Clearly went through quite a good process then. Finally, questions from the public. We have one question, I think. The question was, does the Trust have a partnership with any organisation, public or third sector, to deliver a rapid discharge service for all its patients? And if it does, how is the service measured, and do they consider it to be safe, efficient and effective? Joe, I think you're picking up the answer to this.
Yeah, thanks, Alan. Yes, so many agencies support us with discharge. We've obviously got our partnership with Adult Social Care, Northamptonshire Healthcare Trust, and the voluntary sector support us every day. There's one company that supports us with rapid discharge, and that is a company called Care Home Select, or CHS as we call them. However, we don't hold the contract. That's managed by the Northamptonshire CCG. So the data that they provide us is purely on the number of referrals CHS have, the number of placements they make, the length of stay those patients have in those placements, patient experience and patient feedback. We don't receive any financial information about that contract.
Okay, thank you for that. I think that's a good answer, a complete answer. I'm sure the person who asked it will come back to you if they need anything. Any other business? Well, yes, goodness me. More, Mr. Smith. I think you'd had your show. I'm 10 minutes late because of your loquaciousness. Stuart and then Mark.
Thanks, Chair. Mine's a very, very quick one on the theme of awards, just so everyone's aware. The HSJ Environmental Sustainability Awards, which was a really difficult one to even get shortlisted. We were highly commended for our carbon reduction, the work we've done on anaesthetic gases and removal of single-use plastics, which all sits within our trust priorities or group priorities at the moment. So good news we had this month.
Gosh, awards coming out of our ears here. Mark.
Thank you, Chair. Mine was also a really quick one. David asked a question earlier about the BME risk assessment, which I've now had come through to me. It's 96%. So I will now go and undertake what's happened to the other 3 or 4% that I thought we had, but it's 96% is the official answer.
Okay. Thank you very much, everybody. I think it's been a good meeting, and I do note the point that was made. I think it was Jill who said about, too many strategies kind of thing, and I acknowledge that. But rule number one, have a plan. Rule number two, follow it. I think today we've laid out some pretty clear plans. We've laid out the methodology by which we will measure progress and the stuff that sits behind it to make sure that that is on target. We've laid out what the board wants to do between now and its May meeting in thinking very carefully about the balance between service levels for our patients and looking after our staff, for the two go absolutely hand in hand. Bearing in mind how good this meeting has been, it is worth reflecting that our chief exec has been away for about 4 months on a national role. And all this has been achieved in his absence. And as of the end of this month, he's back. So we can expect, after a week's well-deserved holiday, Simon, that the pace of change increases even further under the leadership of the chief exec. So I look forward to some impressive performance metrics as we start to deliver both the NGH performance and the group performance issues. I apologise for the fact we're late. I'm going to assume that nobody was planning to have lunch in a very short gap. So I'm going to suggest we move straight to the private meeting and thus allow us hopefully to finish it at the previously arranged time. So thank you very much, everybody. Next meeting will be in May the 27th in the usual way, and we'll still be doing it in a virtual way at that point. Thank you very much. See you in the private meeting.